way that you see it's appropriate. Yeah.
Okay, thank you.
On podium, can we go live now?
We can start here.
Yeah, just a couple of seconds. Professor, your floor is yours now. You may start.
Many people joining. It's nice.
طيب السلام عليكم ورحمة الله وبركاته. بسم الله الرحمن الرحيم والصلاة والسلام على أشرف المرسلين. First of all, allow me to introduce myself. It's me. I'm Dr. Ehab Saad Hussein. I'm an assistant professor at National Cancer Institute, Cairo University. Recently, I have joined Saudi German Hospital Group as a consultant of surgery and surgical oncology. I'm holding the position of the head of the department right now. On behalf of Saudi German Hospital and Saudi German Healthcare Group, I'd like to welcome I'm honored to welcome all of our respectable speaker and our audience in this prestigious first international multidisciplinary symposium under the title of Recent Advances in the Management of Colorectal Cancer. Fortunately, we have in this session a group of extremely skilled and knowledgeable professors and consultants across the world. And I believe all of us will have a fruitful time and we will gain a lot of valuable information and knowledge from our expert, respectable speaker. Hopefully this will help us, all of us, to give a better services and healthcare to our patient, getting excellent and more better result. This is all about to be able to help our patient more perfectly. In just a few minutes, if you allowed me, I'll give you a very rapid hint about the Saudi German hospital group. It was like, it started like just, I don't see if can you see it? Yes, now it's visible. In a few minutes, I'll give you a rapid hint about the group. This whole legacy is started with just a simple idea and a dream in the mind and in the heart of the co-founder of this organization, Engineer Subh al-Batarji, and his brother, Dr. Khalid al-Batarji. When Dr. Khalid returned back from Germany and he finished his educational program in Germany, they were ambitious to take this kind of healthcare provided in Germany to their people in Saudi Arabia. They started with just simple branch in Jeddah. Now we have the group have a full-fledged footprint in 6 cities, 6 branches in Jeddah, Asir, Riyadh, Medina, providing a comprehensive network of healthcare covering more than 90% of Saudi Arabia population, with an ongoing expansion in Mecca and in Medina to capitalize on the religious tourism, and further expanding is going on. Recently, in the past year, there was a new transformation led by Vice President Dr. Makarim Al-Batargi. This transformation,
the world is ever evolving, and everything around us is
about in this video. It's a new brand, a new strategy, the whole group going within this strategy. It's well presented in this video.
The world is ever evolving, and everything around us is constantly changing. After over 30 years of existing as a recognized international brand, serving the needs of our community, we too are changing. We are proud to announce that we have embarked on a journey of transformation.
الصوت راح يا إيهاب.
This is not only a name change and visual upgrade, but a portrayal of our rejuvenation, representing progress, innovation, and positive change. Over the last few years, we have been focusing on renovating our hospitals, digitally transforming our services, enhancing patient experience, introducing unique medical specialties, providing advanced treatments, bringing international doctors to the region, and building partnerships with international medical organizations. We have expanded to new territories and now have the largest footprint of hospitals across the MENA region, with plans to expand further globally. Our new visual identity is a culmination of all these milestones and the consolidation of our healthcare and education infrastructure. The original open arm mark has evolved into a welcoming heart shape that speaks strongly to the brand's ethos of caring like family, a promise to treat our patients, their loved ones, our staff, and partners like family. It represents two halves coming together, the relationship between our group and our community, our medical team and our patients, and Saudi Arabia and the world. Saudi German Health represents the fact that we are a global network of hospitals, clinics, medical education facilities, and training institutes, providing a comprehensive healthcare experience, enabling us to continue living out our purpose to improve people's health and relieve their suffering.
So it's all about caring like family. This is what we are trying to achieve, to care our patient like our family. We already, plus the 6 branch that exists in Saudi Arabia, the group have already an operational branches in another countries, like we have a branch in Sana'a, Yemen, and 4 branches in Emirates, Dubai, Sharjah, Amman, and the operational hospital working in Cairo. There are in the pipeline another huge plan of expansion. There is ongoing on a new medical city in Egypt, in New Giza, and in Alexandria under Batargi Medical City. And there will be another 4 hostels in Pakistan and 1 hostel in Morocco and Casablanca. And because we're always seeking for a quality of the service presented to our patient, you will find all of our branches seeking for the accreditation from a well-known organization that's concerned about the quality of the service provided to the patient. So all of the branches accredited with GCI, CPAI, and recently we got in SGH Jeddah, HAM6, all of us are accredited with SCAB, and we are looking for magnet accreditation for nursing and AABP. And because we are always providing new ideas to the world, from 30 years, from 1988, Saudi German Health Group invented the idea of inviting an expert from outside the country, from across the world, to provide a more unique services to our community. Also, we are honored to be affiliated with Mayo Clinic. As we all know, Mayo Clinic, one of the on the top ranking over the whole hospital across the world. Our branch in Cairo and Riyadh are affiliated with Mayo Clinic. This to be a part of the network of Mayo Clinic, our doctor at Saudi German Hospital in Cairo and Riyadh are able to combine their understanding of their patient medical needs with Mayo Clinic, and we can bring the same excellence of service of Mayo Clinic to our patient very close to their home. Through this network, we're using a select group of independent health system in Mayo Clinic that granted special access to all services of Mayo Clinic. Also, as I mentioned, this is the IVB program, which was invented 30 years ago by the group, which depend on bringing the most advanced medical knowledge and clinical skills to the local community by inviting skilled and knowledgeable professors across the world to the group. The visiting consultants are selected based on the patient need and the community need. The visit usually for 1 or 2 weeks per month in a various branch of the SGH, depending on the needs of that branch. Usually, the visiting professors share in medical treatment and surgical treatment of our patient hand in hand with the full-time consultant and the specialty in the branch. Also, they honor us by sharing in the educational and the training activity. And because we are always seeking a quality of service and we are always supporting our society with a society and responsibility and services, the group all the time receiving award from everywhere, from on a scientific committee, from a governor, and here you are a few awards and acknowledgements that was presented to the President Engineer Batargi, Sobhi Batargi, and the Vice President Mr. Makaran Batargi and Dr. Khalid Batargi. That's all from my side. Again, I'd like to welcome all of our speakers and all of our audience. I'm honored and pleased to be with you. And I believe our audience will benefit a lot from this outstanding symposium. I'll leave the floor now for Professor Amr Abal, Professor Mustafa Shazli to start the first session, which is colorectal or metastatectomy colorectal cancer. The mic is yours, Professor Mustafa and Professor Amr. Thank you so much.
First of all, we want to thank the German Saudi Hospital for initiating this scientific activity, and a special thank for the organizing committee, and special thank for my colleague, Professor Ihab Saad. He's one of the very enthusiastic, scientific, and skilled surgeons, which I was happy to work with. And hopefully we'll have a successful and fruitful session, inshallah. And I want to welcome my co-chair, Professor Amr Abdel-Al. He's one of the eminent hepatopancreatobiliary and liver transplant surgeons and professor of surgery in Ain Shams University. And we welcome all the speakers, the distinguished speakers who will share with us their experience. First of all, we want to introduce one of the eminent professors of hepatopancreatobiliary surgery, our dear colleague, Professor John Schmidt. He is one of the visceral and specialized cancer surgeons, and he is now a consultant in Zurich in Switzerland. He will talk about Professor Schmidt. Can you start, please, your talk?
Yes, with pleasure. Can you see it?
Yeah. Yes.
Okay. Well, thanks a lot for the nice introduction. Hello to everybody from Switzerland. I'm really delighted to learn that almost 300 participants are online right now. And the topic I've been given is to give you a nice overview of what is possible today in terms of metastatic surgery in the liver, and what the hepatobiliary surgeons have to keep in mind and have to pay attention to, and how we can select our patients. And I'm sure the discussion at the end of the session will give you some more insight. Now, I've structured my presentation to give you a short overview of these topics, and I will start with the anatomy. As it may sound straightforward, but it's really not, because there's a lot of anatomical variations, and I've just picked the most important ones. And many of you that are active in hepatobiliary surgery know this, but many oncologists and other colleagues probably might not know it. So there's a huge amount of variations. And for example, the liver artery, every fourth patient has a variation. The portal vein is even more frequent. And so we have to watch out for these abnormalities if we do formal and also if we do subsegmental resections, because we have to know where the oxygen is coming from, where the portal vein contributors are, and where the hepatic veins run off. For example, in the bile duct system, there's very important anatomical variations, and I've just highlighted two of them. This one with the red circle represents the entrance of the right posterior bile duct in the left main hepatic bile duct. And there's another variation which is a little bit further distant. So taken together, more than 20% of the patients have an entry of the right posterior bile duct in the left main hepatic duct. And for example, if you do a left hepatectomy and you overlook this anatomical variations, you sure run into a severe biliary fistula problem, because you might deplete the big segments 6 and 7 of the right liver from their biliary outflow. So keep in mind, there's a lot of variations in terms of artery, portal vein, liver vein, and also especially bile duct systems. Now, what kind of resections are we usually performing? And of course, there is an international consensus, like with everything, and I've just highlighted some of the most frequent anatomical resections that we do. You see the brown segments of the are highlighted, and we just have an international nomenclature, so that surgeons, if they say, for example, they do a right anterior sectionectomy, everybody should know what that means. And I think this is pretty important that we have some common ground. If you go to extended resections, like an extended right hepatectomy or left hepatectomy as shown in these graphs, these are still the typical and more or less frequently done resections that we have in our portfolio. Well, there's also the so-called mesohepatectomy or central hepatectomy. If you have the tumor problem located in the center of the liver, and for example, the left lateral liver is too small, you can go with this variation of resection. It's a little bit more demanding, but it has a clear advantage of preserving the two large segments on the right liver, so the operation is safer in terms of postoperative liver function, because the future liver remnant is much bigger, but it has a disadvantage of having a larger cutting surface, two of them, and that of course brings up the biliary leakage rate and hematoma development and so on. So if a patient comes along that is scheduled for liver surgery, we have to know what kind of liver has this patient. And these are just a few examples. Unfortunately, most patients do not have the liver on the left upper and the healthy liver. Many of them have fatty liver steatosis, sometimes even steatohepatitis, which is even worse. And of course, especially prevalent in the Oriental, also in Egypt, for example. Many patients have either liver fibrosis or already cirrhosis. And of course, you have to know very well how good the liver is. And especially in the era of neoadjuvant chemotherapy, it is very important to know what kind of damage has the chemotherapy imposed on the liver. And this is also a reason why we should limit the amount of cycles if we plan in the future to go for liver surgery and not overtreat these patients, because then it becomes more dangerous over time. Also, we have to keep in mind that the Couineau anatomical segmentation of the liver, which you see highlighted here on the computer program, is not the same in every patient. There's huge individual variations. These are just two examples. The upper patient, for example, if you look at the blue segments 6 here, as almost 17% of this liver volume is representing this one liver segment, and the other patient only 6%. So even the rough anatomical segmentation is found in most patients. The size of each individual segments determined by the inflow and outflow vessels might vary a lot, and you have to watch out for those changes. Also, with the modern technology, in difficult cases, we can use 3D reconstruction, computer simulation programs that allow us to delineate the liver in almost every angle. And you can see in this program, you can see the portal vein, the artery system, the hepatic vein, and you can define your transection line and see if your transection line is in the right area or whether a metastasis, for example, is present in the transection line. But usually you don't need these sophisticated programs, but in some advanced and difficult cases, they might be very helpful. Now, in terms of how to transect the liver tissue, I think the gold standard is still worldwide in most centers, the clamp and crushing technique. This is one older study that was comparing the amount of blood loss using 4 different transection techniques: clamp and crushing technique, CUSA, hydrojet, dissecting sealer. And it turned out that the amount of blood loss is lowest with the clamp and crush technique. However, the transection time is the longest because it takes a long time, and there's for many straightforward classical resections, there's an alternative. And I show you one that I prefer, that's the staple hepatectomy. How does it work? You see that if you, for example, if you do a classical right hepatectomy, you can use these vascular staplers to transect the liver parenchyma in a very fast, efficient, and safe way. But you have to make sure that what you transect is really not something that belongs to the future liver remnant. That could be not very useful if you do that. So this is the principle. You insert the stapler after crushing the tissue, and then you fire the stapler. And as you know, the stapler is sealing of both cut ends. And you repeat these maneuvers in 3 layers. Usually 3 layers of these stapling applications are sufficient to transect the complete liver. And this is working very fast and efficient. And I show you a video. I hope you can see it. This is a right hepatectomy case. And this shows you how we do this and why we really like the stapling devices for classical, not atypical, but classical left, right, or left lateral resections. You see this is a pedicle control of the right pedicle. It was transected all together. This is the right liver vein, the cava underneath. And you see it's controlled by the stapler and transected nicely and bloodless. Now you have a devascularized right liver. You see the dark liver on the right side, the pink liver on the left side. You mark this with an electrocautery that delineates your transection line. And then you can use these stapling devices to divide the left from the right liver. You take this specially devised clamp, but you can also use another straight vascular clamp to crush the tissue a little bit. And you see that you apply the stapler, you fire the stapler, and you pull it back, and then you have nicely partitioned this part of the liver. Usually for a right or left hepatectomy, you need about 8 stapling magazines. You might argue this is expensive, but I'm telling you, this video here that you see is uncut. It takes 4 minutes to transect this liver. This is a lot of blood and time that you save, and it really pays off. You have few biliary fistula because you have sealed the structures nicely with the device. And usually, if the liver tissue is okay, it's a very nice technique to transect the liver. But it does not work in cirrhotic or fibrotic livers because the tissue is not soft enough to be stapled. And you see this how it works. For the sake of time, I will continue, but just believe me, it takes exactly 4 minutes for a transection of the liver, and it's usually working very bloodless. And I really personally like it because I don't like to spend time that is not necessary. Okay, now we have studied this in my former institute a long time ago. Now there's many more studies out using the stapling devices. I think it's very feasible for many cases, but of course not for all cases. Very difficult, complex resections still have to be done with the Kelly clamp technique or with other devices. Now, the hepatobiliary surgeon use, of course, and has to know about the intraoperative interventional techniques, because you cannot rely everything on your interventional radiologist. And in many cases, you can combine a classical resection with an intraoperative intervention. You can, of course, utilize the portal vein embolization to increase the contralateral liver. This is one example of a patient that had right dominant liver metastasis, but a small left liver. And this was embolized here by the interventional radiologist, leading to hypertrophy of the left liver within a few weeks. You see on the right hand side the radiographic contrast material in the right portal vein system. This is how it looks on the CT. And you see that the left liver is growing nicely after some 4 to 6 weeks. And then you can, in most cases, do a safe resection. It also works as a nice biotest, because if the embolization is done right and the liver is not growing, it tells you that the liver is sick and you should not do the resection. Now, this is how it looks like after 6 weeks, after an extended right hepatectomy, and you see the left lateral liver is nicely hypertrophic and is big enough to sustain a normal life. Okay, now we also use a radiofrequency or microwave ablation in the operation theater. Sometimes we have 1 or 2 metastases in deeper liver areas in the future liver remnant, and we can use this technique along with the classical resection. But as you know, if the metastasis is close to a liver vessel, be it a hepatic vein or a portal vein, this blood flow here is cooling the heat and transporting the heat away by convection, which is called the heat sink effect. So classical hyperthermic ablation methods have their limitations in the vicinity of vessels because of efficiency, because sometimes tumor cells survive here. And of course, if you need this vessel and you burn it and destroy it, then the future liver remnant could really suffer, and this can lead to lethal complications. So we can use it, yes, but not in every case. And we have a nice alternative for that, which I described to you later. Now, also we have to keep in mind that local recurrence rate of radiofrequency ablation or a microwave is higher, maybe not so much higher than shown in these studies, but is definitely a lot higher in most hands than compared to hepatic resection. So whenever possible, of course, we should prefer resection. Now, what can we do if a metastasis is positioned at a critical area close to a bile duct or close to a supplying vessel of the future liver remnant? And this is the method the technique that was developed a few years ago that enables us to treat these metastases as well. It's called irreversible electroporation. Many of you might already heard about it or use it, but it's a technique that is not working with heat. Essentially, you see here some examples. You place the electrodes around the region of interest, and after some weeks, the liver cells can repopulate the area because it does not destroy this area by heat, but the internal architecture, which is defined by the collagen skeleton of the organ, is preserved. And in the left lower image, you see a pig hepatic vein, which was treated, and this is the main advantage. This technique is not destroying the vessels, it's keeping the vessels patent, at least in most cases, And so you can apply it in metastatic diseases that are located in critical areas. This is the system. I don't want to go too much into detail, but essentially the metastasis is in the center of 3 or 4 electrodes that you place around the metastasis. And even if there's a vessel close by, it doesn't matter. And by applying very strong but very short durated currents between the 2 electrodes, the electrical field in between the 2 electrodes is going to induce apoptosis in livers and in cancer cells that are in this current field. And by overlapping these current fields, you have a complete ablation at the end of the procedure. It works very nicely, but it takes longer. It is more technically demanding, so we use it only for very difficultly located metastasis. This is one example. On the right-hand side, you see the pre-op status of a patient with a solid pseudopapillary metastatic disease of the pancreatic cancer to the liver. And you see this metastasis here is located right around the right portal vein. The left liver is very small, so you cannot do an extended resection. The peripheral metastases were resected, and the central metastasis around the portal vein was with IRE treated. And you see 6 weeks post-op, the right portal vein is patent. The metastasis is completely vanished, and you don't see a scar of the area where you treated. Another example is this case where another spot was placed around, treated around the right portal vein, and after some weeks you don't see, and you see an open vessel. Of course, our oncologists are at least, if not more important, as the surgeons, because without efficient neoadjuvant or adjuvant chemotherapy, we will not be able to cure our patients. So the blood needs to be cleaned by circulating tumor cells. And in many cases, the tumor, the disease in the liver needs to be reduced in size in order to allow liver surgery. This is one example of a very advanced metastatic case, and I'm sure you would or agree with me that this is not operable, even though I just show you the worst images. But after 3 or 6 months of chemotherapy, as in this case, this is the same patient, the disease looks like this. And of course, now the door is open for potentially curative liver surgery. And so we always, and I'm sure all of you do, have to work in concert and together to select the right patients for and the right timing for a liver surgery in colorectal cancer metastasis. And we can also convert many of the unresectable cases that still represent a large part of our patient population. And the responders, which group is getting bigger and bigger because chemotherapy is becoming more efficient, can be converted, and so we can resect more patients. So this is very important. And we also have to keep in mind that every patient that we can render to resection is usually having a substantial survival advantage. This is a study comparing patients that were neoadjuvantly treated, and the group that was converted for resection lived much longer than the unresected patient population. You can also utilize the potential of the liver to grow and do 2-stage hepatectomy, sometimes even 3-stage hepatectomy. This is not a new concept, but of course, it has to be part of an explanation of what we do and how liver surgery works nowadays. This is a typical example of a bilobar disease with a rather small left liver, but 3 of the metastases are located rather peripherally in the left liver, so they can be resected atypically in the first step with the portal vein ligation to the right side. After 4 to 6 weeks, the left liver remnant is grown and much bigger, and then you can do a completion hepatectomy. And this is actually not more complex. It doesn't cause more complications. It causes less complications because it's safer for the patient. So don't be hesitant to do 2-stage or even 3-stage hepatectomy. Now, of course, there's still many cases where we have to say, okay, this is not resectable, but there are some cases that can be treated by using special techniques. And this is the last case of my presentation, just to show you what can be done. Today, many of you in the audience are doing liver transplants, so they know what cold perfusion can do. This is an anesthesiology colleague of ours, 44 years old, who had a huge colorectal cancer centrally located in the liver, encircling the cava, and the left liver essentially non-existent. And we thought this is non-resectable at the first sight, but then we saw this area here, segment 7 and segment 6 liver vein. So this tumor essentially comprised the outflow of the liver. The inflow was not involved. And so this brought us to the idea to do an extracorporeal liver resection with cooling. This is how it was done. The liver was, we did total vascular exclusion. The liver was perfused cold, and the cava was cut. The liver was flipped towards the abdomen, but not completely dissected of its inflow. We did a bloodless separation of the tumor-involved liver and the 2 segments 6 and 7 that were not involved. This the left liver image shows that. And this is the video showing you this operation. We have now done a group of about 15 patients with a similar problem. The advantage of this antecetum approach is that you don't transect the inflow of the future liver remnants, but just, so it's very suitable for outflow compromised, difficult to located primary or secondary hepatic malignancy. You see, this is the view from the assistant. This is the right portal vein here. This is the left portal vein entering the cancer. We have transected the left and the middle hepatic vein. So the right posterior hepatic artery is preserved, and the right posterior portal vein branch is also preserved. You see the demarcation now with segment 6 here and segment 7 here. And this is again, you see these individual variations. It's not a straight line. It's curved and it's different in every patient. You mark it. Now this the inflow on the left portal vein is transected. This is the view from the surgeon's side now. It's transected. The oxygen supply to the future liver remnant is still preserved at the moment. And now at some point comes the time when you clamp the inflow and the outflow completely. We dissect a little bit more. And you see this huge cancer here sticking out or encircling the cava. Now the portal vein is clamped here with a special strong Yazır clamp. The hepatic artery is also clamped, and now the watch has to be stopped, of course, because now it's warm ischemia. The cava is clamped below the liver, and the cava is clamped above the liver. And then you transect the cava below and above the liver. The blood from the liver is, and then you insert the cold perfusion solution in the portal vein, just the same like organ preservation solution, UW usually. You flip the liver out of the abdomen. And now you have time because the liver is cold, and you see the future liver remnant is becoming white. You insert a prosthesis or you do a cable shift operation. That means that you can also take the infrarenal part of the cava and flip it to this area, or you use a prosthesis. Usually you don't need a bypass because the redistribution of the blood usually works fine after 5 to 10 minutes. So If you clamp the cava, you do a probe clamping and allow a few minutes. And in most patients, they remain rather stable. But of course, the time the cava is completely clamped should be limited. Also to predict outflow from the kidneys. So you insert quickly this prosthesis and you restore the backflow. Now the cava is open and you have the time now, because the liver is now 10 degrees or 8 degrees cold and it's bloodless, and you can separate the tumor from the healthy two segments 6 and 7 that will remain, but you deprive it of their outflow because the right hepatic vein was involved by the cancer, and that you separate it nicely. You can also see very well because it's completely bloodless, and you don't need to rush because you have 4 or 5 hours time because the liver is cold, just like in organ transplantation. But it's not a completely ex situ. This is the difference. The risk of this procedure is lower than the one of ex situ because you don't transect the artery and the portal vein of the future liver remnant, which brings up the complication rate quite a bit. So now, after exactly 2 hours, the liver was completely transected. And you see nice the crossing branches, and you separate in this way the thick cancerous liver on the left side, and this is the future liver remnant. You just transect the last contributory for the hepatic vein, and then you have the resection done. But of course, this did not solve the problem completely because you have to reconstruct. This is the specimen that you can see. You see this huge cancer involving the cava and the satellite metastasis here. But the transection line is cancer-free, and this is the specimen. Now the segments 6 and 7 are replaced, and you see here that the inflow is still in place, and we need to reconstruct the outflow. We do this by a saphenous venous patch to reduce the tension between the autograft and the prosthesis. The prosthesis is clamped, it's opened mirror-wise, and then finally the venous outflow reconstruction is anastomosed. So the patch is anastomosed to the opening in the graft. The anastomosis is completed, and then after a few minutes, the perfusion, the air is leaked out. We open first the lower clamp to flush the air out of the prosthesis, and then we open the backflow, and then finally hemostasis and biliary reconstruction is done. So with this video, I hope that I could give you some insight of what is possible today and what's going on in the minds of hepatobiliary surgeons. And thank you for your patience. It took a little bit longer, but I think it was a nice overview to show you what we can do today with liver surgery. Thank you very much for your attention.
Thank you very much for the nice presentation and very informative and very interesting talk. And anyone wants to ask a question? Can I ask a question? Do you use ALPS procedure or you don't use it?
No, I used it, of course, but I think it was overhyped. And I think the complication rate is very high, so I'm not a very big fan. I think you need it only in very, very few cases. I think if you do good operation planning and strategy, in most cases, you don't need the ALPS procedure. But there might be an occasional case where you can do it, but I'm not a big fan of it.
Any other questions?
If you allow me, Professor Mustafa, can I ask
yes, please.
question? Thank you so much, Professor Jan, for the extraordinary presentation. We was just listening. It was amazing, and it's opened a lot of questions in our mind. First, I wanted to ask you about which kind exactly of liver can fit the staple technique. Do you use it with all kinds of liver disease, like, for example, cirrhotic? Can it work with cirrhotic liver?
I think I mentioned this in cirrhotic livers. It's not suitable, and I learned it from you guys in Egypt, what you use, and I also use the Habib sealer here in Switzerland for cirrhotic livers. But fortunately, in Europe, we have much less cirrhosis and many normal or almost normal livers that have soft tissue. And then you can, so in 95% of the cases, I can use the stapling device. It's very fast, so you can do a liver resection in 90 minutes from incision to closure of the skin if it's not a difficult one. And it's saving a lot of blood and time. And I think I like it very much, but you have to know the anatomy. If you staple blind in the liver, it's not a good idea because suddenly the future liver remnant is blue.
Another question about the margin. As you show us, there was a huge metastatic region within the liver, then there was a marvelous response within the liver, very small region. What kind of margin are you going to resect and consider in such a huge response?
Yeah. If you can keep a margin of 1 centimeter is fine, then we try to do it. But as you know, the more difficult the case gets, the closer the margin gets. And I have seen many patients staying local recurrence-free, meaning in the liver recurrence-free after marginal resection. So if for example, there's a vessel, let's say there's a hepatic vein, and you are very close to that vein, but you can get the metastasis without invasion of, I do usually hyperthermal treatment with the argon beamer or with water peroxide. And, it's still better than leaving the metastasis behind. But of course, if you have the enough tissue, you go for the 1 centimeter margin. But even if it's only 1 to 2 millimeters, usually it works in most cases and it stays locally recurrence-free.
And in case of downstage neoadjuvant, you go for the new size, not for the original size, yes?
Yes, of course, yes. And this, the tumor is really shrinking. It's not leaving traces of tumor cells in the shrinkage process, to my experience. The only thing is if the metastases disappear completely, then you have in the center of the former metastasis usually some living stem cells, and the cancer comes back in 85% of the cases in that region. So this is the only exception. But if a huge metastasis is downsized, you can go with what you see, and it's almost normal tissue.
If it vanished by chemotherapy, what's your plan?
Oh, usually have to think about this ahead of time. So if let's say we have bilateral metastasis and we want to do one of the metastases is, let's say, 6-7 millimeters. We know that metastases below 1 centimeter have a high likelihood of disappearing. So we put a clip before, when we still see it, we put a clip in this area that we can identify the area. If the response is very good, we remove the area where the clip was. So you should do this ahead of time. But sometimes, of course, nobody is perfect. It happens that it disappeared and nobody thought about clip marking. Then we leave this area because it's a blind fly. And we watch it very closely every 3 months or every 2 months. And if we see it on CT or so, either we do a percutaneous RFA then,
excuse me,
or something else.
Excuse me.
Yes.
Yes. In such cases, like you were talking about, with, let us say, suspicious or minute residual, which radiological imaging are you relying upon? like, for example, MRI or PET scan?
Yes, no. We always use a Primovisc MRI with liver-specific contrast material and with a 3 or Tesla machine that usually gives you, if the right software is applied, the best sensitivity with regard to liver metastasis. I think this is, I think it's standard among, it's much better than the PET scan. The PET scan tells you nicely what's outside the liver, but it tells you less good what's inside the liver. So usually we do both. If we go for an advanced liver resection, we do a PET scan just to rule out extrahepatic metastasis. And then we always do a Primovisc MRI before starting the chemotherapy, that we have the picture before treatment. And then we repeat it after 2 months. And if there's any metastasis that's going to be too small to find it, either we go for the operation immediately or we put a clip in the area.
Yeah. Thank you so much for your clear answer. But we have a lot of questions really, but I think it's better to move to the second presentation and then have the discussion at the end of the session. Our second presentation by Professor Dr. Ender Dolando. You are with us, Professor?
Yes, I'm here.
Professor Ender, yes, it's our pleasure to have you with us today. In your presentation, Professor Dolando, Professor of General Surgery in Istanbul. He's the director and founder of Liver Transplant Program with a special interest in cancer surgery, liver, biliary, pancreatic, and laparoscopic surgery, and organ transplantation. We are happy to have you with us today, and you can start your presentation. Thank you so much.
Thank you very much, Professor Abdullah, for your presentation and good word about me. It's a great honor and pleasure for me to attend the Saudi-German scientific meetings. And in this sense, I also would like to express my appreciation and thanks to my dear friend and esteemed surgeon, to Professor Ihab and organizing committee. And I hope that our international cooperation will go further in every field in the future. And now I'm going to share my presentation. My talk today is about parenchymal sparing surgery for colorectal liver metastasis. As all we know, colorectal liver metastasis, 20 to 30% are resectable in the beginning of the diagnosis, and some of them become resectable after the downsizing, but this number is still not enough to resect all the patients. So we should have to find some solution for such a kind of patients. And as we know, 5 years overall survival, if we do the resection, is 40 to 60% with the complete resection of the liver, and 6% for patient treated non-surgically. For ideal liver surgeon, surgeon has clinical skills, oncological and anatomical new insights, excellent theoretical knowledge, and of course, intraoperative ultrasonography. Intraoperative ultrasonography is indispensable for the liver surgery. And of course, before the surgery, we should have to think about the risk assessment. As all of we know, volumetry is very important, and using intraoperative ultrasonography is very important. And the function of the liver also is important, because studies show that we can leave the 20% of the liver in the normal person and 30% for the injured liver, for example, with the chemotherapy, and at least 40% we should have to leave in the cirrhotic patients. This is the criteria of Makuichi, which we are using in our department. It is mainly for the cirrhotic patients, but it is very useful also for the patient with the heavy chemotherapy if they have received. As for the definition, parenchyma sparing surgery, because we should have to improve the surgery and number of the patient, and parenchyma sparing surgery is become very important in such sense. I showing you two patients. In the patient A, if you see the right liver full of the metastasis, and in this patient, if you do the right hepatectomy or right trisectionectomy, this can be considered as a parenchyma sparing surgery, even though it's a major hepatectomy. But on the left hand, on the other patient, if a 2 millimeter colorectal liver metastasis is resected by a full segmentectomy, it should not be considered as a parenchyma sparing surgery, even though it's a minor hepatectomy. So in this paper, they show that within 2,500 patients, which included 12 studies, regarding long-term overall survival, the majority of studies didn't demonstrate a difference in overall survival among patients undergoing parenchyma sparing hepatectomy versus anatomical resection for colorectal liver metastasis. And this study also, it's a case study. As is expected, hepatic insufficiency and perioperative mortality is much more lower in parenchymal sparing hepatectomy group. And also overall survival is not so different between the two groups when we look at 1 year survival, 3 year survival, and 5 year survival. And another concept for the parenchymal sparing surgery is R1 resection. R1 resection, of course, the meaning that the microscopic border is positive, but negative margin, of course, is a still standard for colorectal metastasis. But R1 resection is no longer just a technical error, and R1 resection should be part of the modern multidisciplinary aggressive approach for colorectal liver metastasis. As I would like to show you here R1 resection. This is the vessels, and between the vessels and tumor is touching to the vessels, and this is the R1 vascular border. And on the other side, as you see, the between the parenchyma and tumor is this called is R1 parenchymal border, because as I will show you, R1 vascular resection and R0 vascular resection has a similar overall survival. Large tumor, bilateral, multiple, and centrally located tumors, of course, increase the risk to obtain R1 resection. But when we look at the surgical margin, in 1980s, surgeon accept only the border more than 2 centimeters. But by the time, Kokudo showed that at least 2 millimeter is enough. But nowadays, 0 millimeter is enough for surgical margin depend on the case. And as I said to you, we can see in this study also, there is no statistically differences between the R1 vascular and R0 resection regarding to the overall survival. This is one of our case, but I think there is a problem. CT images doesn't work. As you see, right hepatic vein is exposed, and we can see the sulcus of the right hepatic vein, and tumor is exposed in this patient. This is another patient with the tumor between the middle hepatic vein and right hepatic vein, and this is after the resection of the tumor. and it was possible to protect the majority of the liver with the parenchymal preserving surgery. Multiple colorectal liver metastasis is another big problem for the liver surgeon, and for overcome this problem, two-stage hepatectomy is a good option. It was in the past and still using in many of the centers. Two-stage hepatectomy allowed a curative resection in up to 20% of initially unresectable patients. But the main drawback of two-stage hepatectomy, the risk of dropout after the first liver resection reaching to the 25 to 35%, it is not a low number of this. And this is one of our cases with hepatectomy, two-stage hepatectomy we have done to this patient. Intraoperative ultrasonography is very important to do the one-stage surgery for the multiple colorectal liver metastasis, and volumetric data and preoperative planning is very important. And this is a slide of the Professor Guido Torzilli. As you see, many multiple tumors in the both sides of the liver, and it was possible to remove them with one-stage hepatectomy. And this is one of our patients with 12 metastasis, and after the chemotherapy, it was possible to remove all this metastasis. This is another patient with the multiple colorectal liver metastasis, and those are the pictures after the operation of this patient. And this is another patient with the 33 tumor metastasis, and we remove all of them in a one-stage hepatectomy. Using intraoperative ultrasonography and preoperative evaluation of the patient is very important. As you see in this case, right hepatic vein, it was invaded, but there is a inferior right hepatic vein, so it was possible to protect the segment 6 of the patient, and we, as you see here, inferior right hepatic vein and right hepatic vein, and we remove the tumors to protect majority of the liver in this patient. Hepatocaval confidence is another issue and another problem for us. When we define the hepatocaval confidence, any tumor contact with the last 4 centimeter tract of each hepatic vein prior to its confluence into the IVC, we call hepatocaval junction tumors. And to doing this kind of surgery, existence of a common trunk and trunk length and presence of collateral branch emptying either into this trunk or its branch or into the IVC is very important. And this is one of our cases, but in this slide also, unfortunately, CT imaging is not working. In this patient, also patient has a multiple tumor, and also it was located in the hepatocaval junction. And in this case, also it was possible to protect the right hepatic vein and draining vein of the segments 6, as it's shown. This is another patient. This patient also has multiple tumor, and some of them was near to the hepatocaval junction. And it was possible to using especially intraoperative ultrasonography in such patients are very important to do this surgery. This is another case. And this is a mesohepatectomy. As you see, tumor located between the left and middle hepatic vein and touching to the right hepatic vein, and resecting of the tumor with protecting the right and middle hepatic vein, it was possible to do in this surgeon. So partial resection of segment 4 superior and segment 8 with section of the middle hepatic vein, branch of the hepatic vein. We call that mini mesohepatectomy. Surgeon should be familiar with the intraoperative ultrasonography, because during the surgery with such a kind of long surgery, it is not always possible to call to the radiologist. And during the operation, if the patient has a tumor invaded to the hepatic veins, searching for the intrahepatic communicating vein is very important to preserve the majority of the liver parenchyma. And studies show that more than 50%, nearly 60% of the patient has an intrahepatic communicating vein. So with searching this vein, it is possible to do such a kind of surgery. As you see, this is the left and right hepatic vein and portal pedicule. And this surgery calling the tunneling operation. So there is a communicating vein here and continuing to drainage of the liver also. This is another case with the tunneling method. Sorry, and this is another patient. This patient has a tumor on the right, left, and middle hepatic veins. And he was exposed to all the hepatic veins and vena cava. Sorry for the video, it is not so good maybe, but yes, this is the end of the operation. As for the caudate lobe, the location of the tumor in caudate lobe is another difficult location. As we know, caudate lobe has three portions: sphygmal portion, process portion, and caval portion. And we can do three kinds of surgery with the central resection or major resection, right or left hepatic resection, or isolated caudate lobectomy. In this patient, we have done the ventral resection, as you see. And this is another patient. It was possible to protect the majority of the parenchyma with doing the parenchyma preserving surgery. This is after the surgery. We can see the field of the place. Portal veins, posterior and anterior branch of the right portal vein, right hepatic vein, middle hepatic vein, all are exposed. And this is another patient, mainly tumor located on the left side of the caudate vein lobe, and this is after the operation. I think with 1 minute delay, I finish my presentation. I would like to thanks to all of you, and you are very welcome to IASCO World Meeting, which we are going to organize it in 2022 in Istanbul. Thank you very much.
Thank you very much, Professor Delendo, for your very elegant presentation and very a huge advance. I'm working in living donor liver transplant, and I found this parenchymal sparing technique could be at the first of the presentation. I thought it's a type of cherry picking or something with a margin, but then I found that you have a lot of maybe super advanced surgery preserving the hepatic vein outflow. But I have a question. Really, it was sent to me. It can be applied for the presentation of Dr. Schmedet and also for you concerning the vascular invasion. If we have vascular invasion, do you have any idea about the overall survival benefit of this patient if we have IVC invasion, as the case of Professor Schmedet, or hepatic vein invasion, as in your case? As we usually, when we have a macrovascular invasion, usually we see that we have a systemic disease. Do you find any survival benefit? It's for you and for Dr. Schmedet at the same time. Do we have any survival benefit for patients with vascular invasion, or any published research from your center or from any other center concerning this point in specific?
Well, I think from my experience, you have to differentiate what kind of vascular invasion you have. I think arterial invasion usually is accompanied by perineural invasion is much worse than venous invasion, which is sometimes just a matter of anatomical co-localization and finding the cancer too late, so it has touched the vein and it's getting. But if the cancer really has spread completely through the intima of the vein, of course, these patients should all be pre-treated with neoadjuvant chemotherapy, because if you do the upfront surgery and then you find 20 metastases in the lung 3 months later, it's not a good idea. So these are usually all well-selected patients with heavy pre-treatment and good biological selection before you go. I would never do it in the first. Always pre-treat at least 6 months.
I think in the nice video, the very nice video that you presented, Professor Schmedet, that the intima of the vein is not invaded and we don't have a tumoral thrombus, if we can say.
Exactly.
Just the vein is taken, IVC or hepatic vein is taken, no way to resect the tumor except with the resection of part of the vein, whether IVC or hepatic vein, but we don't have actual tumoral invasion.
Exactly.
Am I right?
Yes, exactly. So once you have tumor thrombosis, the story is different, and I would be hesitant. Although I've learned in the last year that, for example, in HCC with borderline thrombosis, I've seen several cases which responded completely through radioembolization treatment. And the tumor thrombus in the cava, in the portal vein, disappeared completely and reopened. So a thing that I would never had thought it's possible a few years ago, because obviously these tumor thrombus sometimes has microvessels that chemotherapy and radioembolization treatment can reach. But this is a different story. But I think usually in colorectal liver mets, yes, select your patients well, and pre-treatment is mandatory if in doubt.
Thank you so much. Dr. Duren, do you have any comment concerning this point?
Yes. Of course, if the patient has an invasion to the vena cava or hepatic veins, we should have to resect that part of the patient. And from the Torzilis group, there is a papers regarding to this, to showing the advantage of the patient regarding to the survival. Yeah. If the tumor is touching to the hepatic vein, sometimes it is very easy to detach the vein. And as you know, Professor Sugioka showed Lunec capsula very clearly in his surgery. And over the hepatic veins or vascular veins, there's a Lunec capsula, which when you reach to this space, in some patients, you can easily dissect the tumor from the venous structure. And also maybe you can use patch as you do, maybe you also in your surgery, when you resect a part of the vein, you can put a patch over it, or you can use the graft for instead of
Yes.
invaded.
Just to conclude for our audience, if the vein is inside the tumor surrounding the major blood vessel, but with no actual invasion and with no tumoral invasion, no way to resect the tumor except with resection of the vein and bypassing it either with a graft, synthetic or natural graft. This is the only way. Yes. Which we think that it could benefit from the oncological point of view and affect the overall survival.
Yes, if the lumen is really altered of the vein, I think that gives you a clue. If it's just if the shape of the metastasis is round, this is usually easy to detach. But if it's irregular in shape and has satellites around it, these are the aggressive ones that are much less well controlled.
Thank you so much. Dr. Mustafa, can you proceed for the third presentation?
I ask a question here. Can you combine surgical resection and intraoperative radiofrequency ablation for other small tumors?
Sure. We do this all the time, yes.
Yeah.
If we resect the dominant part, and if you have one or two spots in the future liver remnant centrally located, do either microwave or RFA, or if it's close to the bile duct or portal vein, then IRE.
Okay. And coming back to the question of Dr. Amr regarding the macrovascular invasion, if there is a thrombosed portal radical, it will be resected with the part, which will be resected, I think it's permissible. Or what do you think? Dr. Schmidt and Dr. Eden.
I didn't clearly get the point. Can you repeat it?
If you have a segment 6 portal vein thrombosis and we resect the whole area of segment 6, it's permissible to resect it, even knowing that this is a part of the macrovascular invasion.
Usually you don't see this in colorectal cancer. In very rare cases.
Yes, HCC.
It's HCC typical, and then you would resect the portal vein up to the main right trunk and get off in a tumor-free area, but don't leave vital tumor thrombus in the liver.
Okay, thank you.
Okay, we can move now.
In HCC, we saw the thrombosis, as you know, maybe. Yes, I agree with Professor Schmidt. Usually, in HCC we see the thrombosis, and colorectal liver metastases. Usually, they are invading to the vessels. Mm-hmm.
But I think,
thank you so much.
To conclude, just as a comment, I think I fully agree with Professor Dundelat that the liver tissue is like a bank account. And if you give away without need half of your money, you don't have savings left for the future. So be very sensitive with the amount of tissue that you remove, as little as possible to achieve the goal. But there's, of course, I think you agree, there's a limit, because biliary fistulas and so on in non-anatomical resections are also posing problems. But in general, yes, save as much parenchyma as you can.
Sorry, can I say one comment? I'm also very happy to hear Professor Schmidt. Also, he's not favor of the ALPS, and I'm also not favor because only very, very limited patient actually really needs to do ALPS procedure.
Thank you, and then we'll move to the next speaker, Professor Volkan Kara, and he will talk about another type of colorectal metastasis, which is a surgical treatment of colorectal lung metastasis, and we're all happy to hear you, Professor Volkan.
So dear chairman, dear presenters, dear colleagues, I'm so happy to be with you tonight. Thank you for having me. This is Dr. Volkan Kara from Istanbul University Cerrahpaşa. Tonight, I'm going to talk about surgical approach to colorectal cancers with pulmonary metastasis, how much we can help the patients as thoracic surgeons. I thank the organization committee for this privilege to be here tonight, and I have no conflict of interest related with the presentations. Although patients gave informed consent for using their medical records, pictures, and videos for scientific purposes. So for tonight, our learning objectives will be background and evidence for pulmonary metastasectomy, patient selection and evaluation preoperatively, the technical choices and variations that we use on the thoracic surgery side, a little bit discussing about open versus minimally invasive surgery and our experience in the university. So tonight's targeted audience will be multidisciplinary physicians involved in treatment and follow-up for colorectal carcinoma. So I'll try to summarize how much and in which ways a thoracic surgery team may help you. So if we have contributions from thoracic surgery side, some of the parts may be simple for them, and I'm sorry for that. So as the general information given the whole today, this very nice organized meeting, its rate is increasing and many patients are coming on the field for looking treatment. But unfortunately, like 20% of the patients are stage 4 disease, and these metastatic disease are our aim. As previously presented from our former presenters, liver is the most common place for metastasis. But lung is coming on the second side, so we are trying to decide what we can do for these patients. If you do not treat patients with stage 4 disease, it's unfortunately not more than 12% for 5 years survival. But in pulmonary metastatic patients, if you do metastasectomy, it raises up to 40%. So the term synchronous and metachronous has been discussed for liver, which is definitely the same for the lung. And generally, resection of pulmonary metastasis from non-pulmonary malignancies has been adopted as a cure treatment modality from the recent years, starting from 1940. But for the resection of metastatic tumors is well defined in 1965. And unfortunately, with this very low group, only 25% of the patients will be appropriate candidates for surgery. From the previous sessions, I must say that we are more conservative compared with liver surgeons. We are more selective, and we are hoping to be additive. And according to the literature, there is a consensus, at least decision of the literature due to center-based information, long-term survival would be given for the patients who have lung metastasis following colorectal cancer. So surgery is strongly advised. Even there are some limitations, many centers today advise colorectal cancer's metastasis should be excised surgically. The history was depending to 1944. And I said before, depending on the center's experience and point of view, it has still been discussed, but preferred for more oncological groups. Solitary single lung metastasis is definitely accepted for resection for many physicians, but multiple and bilateral lesions are still controversial. On the cons side for metastasectomy, pulmonary metastasis is a sign of systemic disease. So even if you perform surgery, the risk for systemic recurrence is still existing. And the real addition for resection for these patients, when we compare the numbers, may be questions. And meanwhile, for the treatment for surgery, the treatment for chemotherapy may be delayed. On the other side, where metastasectomy is supported, excision of a lesion gives a definitive diagnosis, which requires some differential diagnosis for this patient. And surgical excision is a good modality for a solid malignancy as general. And spread of the disease may be slowed by excising the solitary component. And also, the tissue that we get from the pulmonary side may help you for future treatment depending on the medical choice. Unfortunately, the prospective data, comparing data for metastasectomy is still lacking, and randomization is quite difficult according to the physician decision protocols. So we still continue working on our personal expert experience. There is a prospective randomized study from a research group which has been published as a multicenter study, and only 65 patients could be randomized, even it was a multicenter study and could be monitored. And according to the 5-year survival rates, there were not too much different in between the patient with the follow-up group and surgical excision. But on the other hand, when you look overall survival to metastasectomized patients, the currently considered treatment modality due to better result for these patients. So we generally make our decisions, of course, on our personal experience, but guidelines are fine. So when we look at the NCCN guidelines, as you most of you very well know, the metastasis coming from the follow-up period of a colorectal cancer, resection is generally offered. So if a patient has a colorectal primarily controlled cancer, please do perform metastasectomy. If an extrathoracic disease in between existing, treat the disease and then refer to the pulmonary center for thoracic surgery resection. So our aim, compared with the general surgery team, we have to aim R0 resection, because existing tumor left behind would be threatening us for the near future. But meanwhile, as Dr. Schmidt has very well mentioned, as your account in the bank, you have to preserve the lung tissue for the future requirement for surgery. For these patients, they have regular physical examinations. As you know, carcinoembryonic antigen is followed up. Colonoscopy is a way of following up this patient, and some other additional radiological tools are used. Generally, a routine chest X-ray may not be helpful, but a computerized tomography, a multi-detector CT scan, is very helpful for us to define a metastatic lesion in the lung. So this patient was a right upper lobe metastasis following colorectal cancer. In addition, positron emission tomography scan is generally helping us to see the metabolic activity, not only in the lung, but also in the general body. I must say that PET scan is our routine for a lesion in a computerized tomography, because we are dealing with too many non-small cell lung cancer, small cell lung cancer. Even there are some PET active benign lesion, inflammatory responses, and we have been seeing patients in COVID-19 period that they are not tumoral, but show an effective PET uptake. So this patient, just to be additive, has a PET evident lesion on the right upper lobe and suspicious of tumor, but totally was a reaction of organized pneumonia. Preoperatively, before surgery, if you decide for surgery, we prefer to have a diagnosis because of the reasons, because those patients with colorectal cancer may have a primary lung cancer, which totally changes your strategy. If we decide a patient for surgery, general medical fitness, cardiopulmonary fitness, and pulmonary function, including exercise tolerance testing, should be well measured. So these patients are candidates for even pneumonectomy. So we have to measure the possible risk and define the availability for resection. But in addition to normal patients that have colorectal cancer surgery following by a chemo, these patients have additive lung risk due to the medical treatment, oncological treatment that they have. Anesthesia is very important in our job. We have to have a non-inflated lung during surgery. So we have very qualified anesthesiologists, which gives us opportunity to not inflating the site that we are working and inflating the other side. So that needs a selective intubation. When we come to our choices in surgical techniques, video-assisted, camera-assisted, closed technique to open, there are still different talks. For the open surgery side, the occult disease may be found in the contralateral side. So some of the surgeons, some of our colleagues prefer to touch the lung during surgery to be sure that there may be additional nodules despite the existing computerized tomography or the other diagnostic tools. And minimally invasive surgery methods do not let us to touch the lung by itself. So generally, decision is surgeons. There are some studies comparing how much the touching the lung would be additive to the patient. This is an old study, but a randomized study. And in that study, like 30 patients of 150 had an additional nodules. But I must say that till then, the technology in diagnosis has evolved. So we are generally trusting on our radiology part. So in the open, the conventional part, there are different types of approaches. The most common one that we use is posterior lateral thoracotomy. I mentioned posterior lateral because most of the patients are fine with lateral thoracotomy. It gives a great exposure. It helps us to go into the thoracic side, palpate the lung, touch the tumoral area, and excise the lesion. These are just 4 or 5 centimeters incisions. The patients should be separated to make the intercostal areas more open and widened. We try to perform muscle-sparing thoracotomy to decrease the tissue damage, which would affect on the post-operative pain. And this generally, serratus anterior is divided into fibers, but not cut. This causes less tissue damage. So posterior lateral thoracotomy is our main approach for open. But for bilateral lesions, theoretically, we can perform a median sternotomy to reach both sides. But we must assume that this is a larger surgery. And in addition, if you need anatomical resection, for example, lobectomy, sternotomy is not the best way to approach to thoracic cavities. A clamshell incision also as literally existing an alternative for bilateral lesions. As I said before, if a patient has a single site lesion, we perform thoracotomy. If patient has 2 site lesions, we perform sequential thoracotomies rather than doing in the same time. So when we come to the minimally invasive surgery, which we abbreviate as VATS, started from 4 ports, now decreased to 1 port. As you know from your laparoscopy experience, without spreading the lips, we insert a camera and try to perform all the surgical procedures as we do. Like you all know, the minimally invasive surgery has an advantage for reduced scarring, decreased postoperative pain, shorter hospital stay, hospital costs, lower risk of some of the complications, better surgical outcomes is still discussed, but reduced immunosuppression is clarified. So on my side, as a guy who likes medical education, this recording gives us opportunity for better teaching due to recording options, which is very important during pandemic, which cases has been decreased worldwide. But what needs education, it needs underlying facility. And on one side, for some economical reasons, it can be expensive due to the video camera system and the static devices that you use. We have also combinations, which can be a hybrid approach, combining VATS with open techniques. You insert a camera, but you also perform a thoracotomy. So it varies. The coming future, which is also very expensive, is robotic assisted systems. It also needs education. It needs maybe decades to be dispersed all around the world, but it is used. When we come, how much resection of the lung will be performed? sublobar resections, which is a wedge resection or a segment resection, is preferred to keep the reserve for the future. But we should be keeping in mind, if you entering a thoracic cavity, the patient should be ready for a lobectomy or a pneumonectomy. So we make our decisions on that time. On the parenchyma sparing approaches, there is also a laser or electrocoagulation, which is also less than a wedge resection, just circumcision the around the lesions. But you should be keeping in mind, laser also needs an underlying facility, and this causes much more tissue damage because you don't use the stapling devices. So post-operatively, these patients may have air leakages. So lung preservation is our primary goal, and optimization quality of life with this preserved lung tissue is important because these patients will continue having chemotherapy, as I mentioned, which are also toxic to the lung and the heart. So our general approach worldwide is doing a sublobar resection. And if a lesion is located centrally, we may have to perform a lobectomy. And in these cases, you should be very careful with the patient's pulmonary function that I have already mentioned. So the size, as I listened from the previous great presenters, our aim is to create a tumor free of at least 1 centimeter margin from the distance. So we generally use a green stapling devices, and we try to make the distance away from the surgical margins. So I must say that on our point, there is no proven different oncological results in open and VATS. I add my experience and literature, not only in colorectal metastasis, in also lung cancer. So either open or closed, it depends how much high quality surgery you perform. So do perform an en bloc or zero resection, and this would be the best technique that you know. Lymph node dissection following surgery is also discussed. So some of the surgeons prefer routine lymph node dissection meanwhile. On the other side, depending on our high qualified PET-CT reports, if the PET-CT do not mention about any lymph node metastasis, you may not do that. So when I come to our results in our facility, 22 patients in the last period, I must say that these patients, sorry for this, this is 2021, but for the last 1 year due to pandemic, the numbers had decreased. We had 32 patients. All patients have these metastases during their follow-up. I have to thank our general surgeons and our medical oncologists for their close follow-up. The mean age of those patients are 62.4 to 66.2, and only four of them had preoperative diagnosis by transthoracic aspiration. Only 4 of them had thoracotomy. You can see that our most resection choose is minimally invasive, and as you see, 29 of those patients have wedge resection. Only 1 patient has, due to central location, had lobectomy, and 1 patient has segmentectomy. When we come our follow-up data, 3-year survival is 70%, and 5-year overall survival is more than 62%, which is parallel to the existing literature. Hopefully, no intraoperative or in-hospital mortality occurs, but 24% of the patients have minor morbidities like wound infection, prolonged air leak, which cause increase in the hospitalization time, and wound pain. Those patients have continued their oncological treatment, and the patients are overall satisfied with their results. I would like to show you some cases which would support the speech that I have given. So this is a 76-year-old male, had adenocancer of the colonic area. He had surgery and chemotherapy. On the 3rd year of the first diagnosis, unfortunately did not have follow-up in the last 12 months, had multiple lesions on the chest X-ray, as you know. And when we have the computerized tomography to define what's going on in detail, we have seen that he had a lesion on the right side, but he had also multiple lesions on the left hemithorax. The patient's respiratory functions were okay, the physical status was good. So first he had left thoracotomy, had multiple wedge resection, and they were all verified at adenocarcinoma metastasis. And after discharge and 1 month waiting, he had right Watts wet resection, and also that was verified as adenocarcinoma metastasis. This patient is alive and healthy on the 6th month of the. So this is the last computerized tomography of the patient. This is a recent tomography, and you can see that all the lesions are gone, but if I can go forward, the patient, okay, it's gone. So the existing lesions preoperatively are gone, but he had an additional lesion on the right lower lobe. So it's coming, sorry for showing it again. So these are the areas for stapling devices, the previous lesions, but there was another giving lesion. So we offered surgery for this patient and waiting about his response. Another case, 72 years old male, adenocarcinoma of the colon, had resection followed by chemo. He had a level lobe lesion in the follow-up. Unfortunately, no tissue diagnosis preoperatively. So you'll see a left lower lobe lesion. Had an adenocarcinoma, probability of metastasis is high. So the lesion is coming, as you see here. So we had left Watts wedge resection. On the frozen section that we routinely perform, it was adenocarcinoma, but not classified. We finished the operation, but definitive pathology revealed primary lung adenocarcinoma. It's a surprise. So we performed a completion lobectomy. So don't forget, you may need to reoperate those patients, and pathology is a key actor in the team as always. A more detailed case, I will be ending my session, 58 years old female, adenocarcinoma, again resection, followed by chemo. She had a right lower lobe lesion in the follow-up. So for some of the patients, chest X-ray will not be enough. So please keep in mind that tomography, computerized tomography, is very valuable for those patients. As you can see, coming, and in the PET-CT, different lesions. And I'll show you the right side video. This is a Watts resection. So we enter the area using the clamps. So moving these clamps sometimes help you for the lesions that you cannot see directly. But for these patients, we were lucky and we can see the lesion just located. We generally position a clamp to see the exact tissue size, so we can place the stapling device. You can see the drawing. So this is the exact positioning of the patient, as you can see, and we are aiming to do this wedge resection thing. So we don't care about some small additional incision. So this is a three-portal approach. So we know where the lesion is. We have just passed the clamp under it. And now, without touching the tumor, just near to it, we are taking it up, placing the stapling device beneath the lesion and pushing it. So as you know, this stapling device are magically, so gives us opportunity to cut and sieve the areas, and we pay attention. We decide not to too much take from the parenchyma. So the resection is about to finish. So the total time for this, for generally this is a residence case. So we try to mentor them during this things, because it's when we compare our general work, it's quite easier cases. So we use generally a few step link devices, and as a general approach, so the limited resection from the parenchyma is important. We wait for the tissue bag, put it inside, and take it out, and we directly send it to the pathology for frozen section. So for take-home messages, we have better survive for the selected patients with metastasectomy. Radiology and nuclear medicine technologies are trustable and helpful for us. Patient selection is the key point, and we have to plan a good preoperative plan. Either open or close, doesn't matter, do the best that technically you and your team can achieve. If not, excision is offered, may be done, and dedicated surgical team, thoracic surgical team is ready to help you. So we work as a big team. That's a real case, waiting for the frozen section results. We worked during the pandemic. So I'm very proud of them. I am doing this presentation on behalf of my team. So I thank you for your attention. Very nice to meet you all, and we wish to meet you again face to face. I'll be so happy for your questions, contributions, not only today, for email, you can directly text me, and thank you.
Thank you, Professor Volkmann, for this nice and collaborative presentation, comprehensive presentation. And I think this gives more hope for our patients. Hope. Anyone wants to?
I think we can leave the question, but because we are out of time, if we can leave the question at the end of the session. What do you think, Dr. Mustafa?
I think yes.
Okay, thank you so much for the elegant presentation. And now we move to the debate session. All colorectal cancer patients with synchronous liver metastasis should have synchronous surgery, yes or no? We have with us today our professors, Dr. Hemant Vadar, a gastrointestinal and liver surgeon, working in and he's working in hepatobiliopancreatic unit in Nottingham and Manchester in UK. And the Professor Dr. Shafiq Sidani, Professor of Hepatobiliopancreatic Surgery in Abu Dhabi. We will have the debate between both of them, and they can start now, if possible.
Thank you so much indeed, Dr. Abdullah. My name is Said Rafi. I'm a consultant medical oncologist, and welcome to this debate session on a topic that is very frequent and we come across on a frequent basis in our MDTs. A patient with colorectal cancer presenting with a synchronous liver metastasis. And there are many aspects of this that is matter of debate in our MDTs on a frequent basis. And I have asked two of my dear colleagues and friends, Dr. Hemant Vadayar and Dr. Shafiq Sidani, to discuss for and against synchronous metastasectomy in this group of patients. Dr. Hemant Vadayar is a consultant hepatobiliary surgeon at Medical Clinic City Hospital. As previously said, he has previously been working in Manchester in the UK and also in India, and currently working at Medical Clinic City Hospital in Dubai. Dr. Shafiq Sidani is also another dear friend and colleague, consultant colorectal surgeon, head of colorectal surgery at Cleveland Hospital in Abu Dhabi, previously worked and trained in the USA and recently moved to, not so much recently, for 5 years in Abu Dhabi. So if I can start, Hemant and Shafiq, with you guys to go ahead and perhaps make your point. Then I have a case that we can quickly discuss, and then I have also a few questions that we can discuss and then see what we can reach. So Hemant, would you like to go first?
Yes, hi, Said. Thank you for inviting me to be part of this conference. Can I start sharing my screen?
Yes, please go ahead.
Okay, so my topic is that about combined liver and colorectal resection for synchronous colorectal liver metastasis. This is not so much a debate as to sort of understand in which patients can we do combined resections and which patients may not be suitable. So there is no dogma about it. It's not a dogmatic debate. So I'd just like to give you the principles of how to manage synchronous colorectal liver metastasis going forward. So basically, we know that synchronous colorectal liver metastases are now present in about 15 to 25% of all colorectal cancer cases. And the incidence is increasing. And the reason it is increasing is partially because I think we have got much better imaging, and therefore we are able to detect metastasis, which probably we were not able to detect some years ago. Out of these patients, in most of these patients, the metastases are confined to the liver. So therefore, there is a potential for some form of curative therapy at some point. Surgery plus or minus chemotherapy remains the most effective treatment for management of colorectal liver metastasis, whether synchronous or metachronous. But we all know that synchronous metastases have a poorer prognosis compared to metachronous metastasis. However, there are multiple management options, but there is no randomized controlled trial or a grade 1 evidence for what might be the best plan. So therefore, we have to rely on a number of case studies, reports, and some guidelines from various organizations to help us in deciding what might be most suitable. So the questions that we have to ask in synchronous metastasis are, first of all, is the primary tumor symptomatic? Are the liver metastases resectable at presentation? Should systemic therapy be administered as the first treatment? Should the surgery be done in 1 or 2 stages? And if it is in 2 stages, should we do the colon first or the liver first? And looking at all these things, there are a number of potential scenarios that come to mind. So traditionally, what has been happening is that patients with colorectal liver metastasis who presented synchronously first underwent the colorectal cancer surgery, then underwent chemotherapy for a few months, and then, assuming the liver was still operable, underwent liver surgery. The problem with this, however, was that the chemotherapy got delayed because of the recovery from colorectal cancer. And in case they had a complication such as an anastomotic leak, etc., that would delay it even further. Second question was, what would you do if the primary was not symptomatic? Would you still go ahead with colorectal surgery? And what happens if the liver metastases are unresectable, either at the primary stage or at a later stage they have become unresectable? So with this, with the advances in chemotherapy that our medical oncologists are now able to achieve and the good outcomes, there are now a number of different approaches that are potentially feasible. First is that you give the patient chemotherapy plus or minus radiotherapy depending on the location of the primary colorectal tumor. Then the patient then follows the classical approach of the colorectal cancer surgery, followed by some more chemo, and then a liver surgery. Alternatively, the patient, after receiving the initial chemo plus minus radiotherapy, may have a combined colorectal and liver surgery at the same time, which is one of the important points I would like to emphasize today. Or after having chemotherapy, the patient might have a liver surgery first, further chemotherapy, or directly going to colorectal surgery. Or in case it's a rectal cancer, they can have radiotherapy for the rectal cancer in the window between the liver surgery and the colorectal cancer surgery. So these are all the various scenarios that can be feasible in today's practice. And let us see how we evaluate all these different options. Sorry. Okay. So in most patients nowadays, we would give them early systemic therapy. The reason for that is because now we know that synchronous colorectal liver metastasis is a systemic disease. the prognosis for these patients is not driven by the primary tumor, but it is driven by the state of the metastatic disease. And therefore, it is important to try and tackle the systemic spread or the potential systemic spread beyond the liver as soon as we can. We also know that there are increased rates of resectability now for unresectable colorectal liver metastasis based on the chemotherapy and the targeted therapy that our medical oncologists are able to achieve. Preoperative systemic therapy results in conversion of 15 to 30% of patients from non-resectability to resectability. And although less clear, it is also recommended now for resectable synchronous metastasis to give chemotherapy first. Again, there is no randomized control study or grade 1 evidence, but it is something that is practiced by most places. So what are the potential benefits if we decide to do a combined resection? It will be a single surgical procedure, which is of course desirable in most patients. It will reduce the risk of anesthesia because you would have one anesthetic procedure rather than two anesthesia. It avoids the difficulties of having a second surgery, which will be inevitable due to adhesions, potential injury to other organs, etc. Potentially, it has the chance of reduction of overall hospital stay. But there are some questions that need to be answered before we can think of this as a technically feasible option. Is it feasible? Is it safe? Is it efficacious in terms of the oncological principles and oncological management? So let us see how we can try and answer these questions. There are a few studies, as I said, there are no randomized control studies, but there are a few studies that have looked at this particular question. This was published way back in 2003, which showed that they had 134 patients who had a combined resection versus 106 patients who had staged resection. Mind you, this was before a number of the chemotherapy and targeted therapy agents were available, which are available for us today. So this series, they did a combined resections mainly for fewer and smaller liver metastasis and mainly for right-sided colonic tumors. And they showed that in the combined resection group, they had reduced complications, decreased median hospital stay, and decreased perioperative mortality. There was a multi-center study published in 2015, which looked at 142 laparoscopic liver resections combined with laparoscopic colorectal resections, because nowadays most colorectal resections are being done laparoscopically. Median number of liver lesions was 1. So again, lower number of lesions. Median size of the largest lesion was 28 millimeters. Again, more suitable for smaller liver lesions. Only 7 patients had to be converted to open, that is about 5%. The morbidity of the procedures was about 31% and mortality was only about 2%. And the overall survival at 1, 3, and 5 years was shown to be 98.8%, 82%, and almost 72% at these points in time. There was another literature review published a few years ago, which combined 20 different publications, which included 150 patients, of which 139 had laparoscopic resections and 11 had robotic resections. Majority in these situations were rectal tumors. The conversion to laparotomy was only 1 patient. Again, most patients had minor hepatectomies, less than 3 segments, and morbidity was 27, about 18%, and mortality was very low at about 1.3%. The hospital median stay was only about 8.5 days. So based on these reports that we have, we now know that combined resection is technically feasible and safe. It does have acceptable surgical and oncological outcomes. It does provide us with all the benefits of a single surgery with a reduced risk of morbidity, reduced risk of overall mortality, and a reduced hospital stay overall. However, the key to success is careful selection of patients. These patients must have smaller lesions and they must have fewer lesions, which means that the smaller lesions generally is accepted as less than 5 centimeters in size on an average, or less than 3 tumors, or less than 3 segments involved in the liver. So therefore, the liver resections generally are minor resections, which are less than 3 segments of the liver. And usually it is only suited for right-sided colonic tumors primarily, especially if we are thinking of doing bigger resection. For a left-sided colonic tumor or a rectal tumor, it is only advised if we would do it combined with a small resection, maybe just a wedge resection or a single segment or a couple of segments to be resected. A lot of the data for currently understanding our liver metastasis has come from the Liver Met Survey, which is an international registry of all patients operated for colorectal liver metastasis, administered from France, with more than 260 international centers and over 30,000 patients registered. Most of the data is retrieved from this collective experience. However, we must understand that this is experience which is therefore potentially has some bias and is not randomized controlled study of any sort. But we can learn a few lessons from this. And a few years ago, based on this data, there has been some guidelines provided for managing synchronous liver metastasis from colorectal cancer, which was a multidisciplinary international consensus by a group called the EGO-SLIM, which stands for the Expert Group on Oncosurgery Management of Liver Metastasis. This group it looked at 4 clinical scenarios. We could have a symptomatic primary with either resectable metastasis or unresectable metastasis. When we say symptomatic primary, we mean that the patient may present with an obstruction of the colorectal tumor, could be presenting with a perforation or bleeding. Second situation is the patient could be completely asymptomatic from the primary, but may have resectable or unresectable liver metastasis. So the guidelines are given for all these different scenarios. So if we look at the first scenario where we have a patient with a symptomatic colorectal cancer, with resectable metastasis, the consensus said that patient should have upfront primary surgery. Clearly, that is indicated for bleeding, obstruction, or perforation. Most of the time, bleeding may not be an indication. Chemotherapy may control the bleeding, but perforation and obstruction are clearly indications for primary surgery. And then we give chemotherapy followed by liver surgery. So this is one of the situations where we follow the classical approach of the strategy of management. Let's look at symptomatic colorectal cancer with unresectable metastasis. Again, the same situation where the primary is operated first because of the obstruction or perforation or maybe bleeding. And then we give chemotherapy. And the aim of chemotherapy here would be to make the liver metastasis resectable. If they become resectable, then we proceed with second stage liver surgery. So this is very clear that if the patient is symptomatic from the colorectal cancer, then primary colorectal surgery followed by chemotherapy, followed by liver surgery is the treatment of choice. Let's look at what happens if the patient is asymptomatic. If the patient is asymptomatic, the consensus recommendation from the expert group was that we give them chemotherapy or plus minus targeted therapy before the surgery. If patient has a mid or a low rectal cancer, the radiotherapy is recommended with no one-stage surgery. One-stage surgery is recommended for easy to resect, like I mentioned, primary tumors with limited, that is less than 3 segments liver metastasis. If we have colonic and upper rectal cancers, no one-stage surgery for complex colonic tumors, high-risk patients, or if there is a major hepatectomy involved. However, in these patients, once they have responded to your chemotherapy or after the chemotherapy has been administered, we should consider a liver first approach, because again, we follow the same principle that the metastatic disease is what is going to determine the prognosis for these patients. And therefore we must tackle the metastasis first, especially if the primary is still asymptomatic and can be either resected along with the metastatic disease or could be resected at a later stage. So liver first approach is something that is becoming more and more practiced in most liver centers. Again, asymptomatic patients with unresectable metastasis, the first step, of course, is to give chemotherapy or targeted therapy. No simultaneous surgery, because most of these patients would often require an extensive liver resection. If liver metastases do become resectable, here the consensus is for a reverse approach to the liver first. If required, sometimes we may need to help with increasing the future liver remnant by doing portal vein embolization or a staged approach, or combining with a radiofrequency ablation or microwave ablation, just as Professor Schmidt showed us. Whatever the reason, again, the liver metastasis should be tackled first in order to reduce the chances of systemic disease. And then we approach the colorectal cancer, either if possible in the same sitting, which is unlikely in these situations usually, but at a second sitting. And if it is a rectal cancer, then we give the radiotherapy in the window between the liver surgery and the rectal surgery. So in conclusion, I would like to say that show this algorithm for management of synchronous metastasis, where looking at the primary, if the primary is symptomatic, we always do the surgery first for the primary for obstruction, perforation, or bleeding. However, if the patient is asymptomatic from the primary, then we look at whether the patient has got a resectable colorectal liver metastasis. If they are limited colorectal liver metastasis, we could even look at primary combined surgery. That is before giving any kind of chemotherapy, because many situations, if the metastases are small or less than 3, after giving chemotherapy, the metastasis may disappear, and that may make surgery of the liver more difficult. And if it is feasible to do the surgery at this stage with minimal morbidity, we can consider doing a primary combined surgery. Otherwise, we give them chemotherapy plus minus radiotherapy and then surgery as a combined approach. That is the liver and colorectal surgery at the same time. If there are extensive liver metastases, even though they may be resectable, that is more than 3 segments or bilateral, we give chemo first. And as a second stage, we do the surgery, as I mentioned, with the liver first approach and preoperative radiotherapy if it is rectal cancer. If the liver metastases are unresectable, we give chemo first and then surgery at the second stage, potentially liver first approach, and then preoperative radiotherapy if it's rectal cancer. So thank you. That's my presentation. And thank you, Saeed. I'll hand over to you. I'll stop sharing the screen.
Thank you so much indeed, Hemant. It was very informative. So there must be something, Shafiq, that you do not agree with.
Hard not to agree with all that. So let me share my screen for a moment. Let me know if it's not sharing.
Yes, we can see your screen.
All right, excellent. Thanks, Dr. Saeed and the organizing committee for inviting me, and nice talk, Dr. Hemant. So today I was tasked as part of this debate to argue against simultaneous resection for synchronous colorectal cancer liver mets. Dr. Hemant did most of the job for me, but I'll continue real quick and be brief. I'm just going to present 3 quick cases just to kind of illustrate the argument against synchronous, against simultaneous. So the first case is a quick case, 50-year-old healthy man, no comorbidities, asymptomatic cecal cancer on a screening colonoscopy with a kind of slightly elevated CEA, and the staging CT scan shows a single 2-centimeter liver met hanging off the left lateral segments, no other extrahepatic mets on PET scan. I think this is an easy case, and most of us would agree that we would proceed with a simultaneous resection, but most of our cases are not really that. These next 2 cases will illustrate the argument against simultaneous. The second case, 75-year-old sick man with coronary artery disease and other comorbidities. He was diagnosed with a T3N2, so a locally advanced distal rectal cancer with a high CEA and bilobar liver mets, considered potentially resectable on a multidisciplinary tumor board discussion. He has no extrahepatic metastases, and he gets neoadjuvant chemotherapy for only 2 months with a good response. And the HPB surgeon says it's resectable with a portal vein embolization. So this is the type of patient I would say is not a good fit for a simultaneous resection. This is a major hepatectomy with portal vein embolization and a locally advanced distal rectal cancer. So I would not approach this in a sick man with a simultaneous approach. This is one in our institution we'd do probably a liver first on. Case 3 is another straightforward case. 70-year-old man, some comorbidities, comes in acutely to the emergency room with an acutely obstructing cecal cancer. And on staging CT, he has a 2-centimeter. He has 3 2-centimeter right-sided liver mets. So this needs emergency surgery. He's acutely obstructed. He needs a right colectomy, but I wouldn't do a hepatectomy on this gentleman in the acute emergent setting as well. So another case for not simultaneous. So a few disclaimers before I present some data. I'm a colorectal surgeon. I'm not an HPB surgeon. Very importantly, I think Dr. Hemant mentioned this, there are no randomized trials comparing the approaches. all of it is retrospective or prospective case series. And they're mixed with colon and rectal cancers with different chemo and radiation regimens and a huge selection bias as a result. The other thing is frequently we do simultaneous approaches, but my job here is to argue against that. So as I said, there's a huge selection bias in these studies. Most of these are retrospective, so the patients selected for simultaneous are easy cases, straightforward minor hepatectomies, colon cancers rather than rectal cancers, healthier patients rather than sicker patients. And this was shown in a recent meta-analysis in 2019 of 32 studies comparing the staged versus simultaneous approaches. And you can see in these studies, kind of including all the previous studies, that there's a higher number of rectal cancer cases in the staged approach, and there's a significantly less major hepatectomy rate in the simultaneous approach. So really inherently in all these studies is a selection bias towards easier cases, if you like. This is one of the larger studies, larger series from the US that looks at 610 patients in a multi-center fashion. Some underwent simultaneous, some staged. But basically, when they looked at those patients who specifically underwent a major hepatectomy, either simultaneous or staged, the mortality rate was significantly higher, so 8% versus 1% with a simultaneous approach. And severe morbidity was also significantly higher. This is, combined severe morbidity of both the staged surgeries versus the simultaneous surgery. So really, more morbidity and mortality with the simultaneous approach for major hepatectomy. And then when this particular study from France looks at oncologic outcomes, and they compared their single center experience with simultaneous versus staged, and their progression-free survival over 3 years and recurrence rates over 3 years was statistically significantly worse with the simultaneous approach. The advantages of the BAL first approach, so there are two staged approaches, as Dr. Himant mentioned. There's the BAL first approach or the liver first approach. And the advantages of the BAL first approach is you address the symptoms of the primary tumor initially, and that minimizes treatment interruptions related to complications from the primary tumor like obstruction, perforation, or less likely bleeding. And if after the BAL first approach, the liver disease becomes unresectable or blossoms, then you avoid an unnecessary large hepatectomy if the disease progresses. And on the other hand, you can argue, and some have argued, that if you give time after a bowel resection, more liver lesions may arise in different parts of the liver, and you eventually end up with a more accurate liver resection if you do it afterwards. Arguable, of course. The liver first approach has certain advantages. First of all, it avoids the morbidity of the simultaneous approach when you're doing a major hepatectomy or even a staged hepatectomy or portal vein embolization or ALPS or whatever. It addresses the survival determining metastatic disease first, especially when the primary tumor is asymptomatic. Should your metastatic disease blossom or you develop extrahepatic disease after the liver resection, you can avoid needless colectomy or pelvic surgery if the primary tumor is asymptomatic. It's a great approach for staged hepatectomies, and sometimes you can do, the larger stage alone, and then the smaller stage hepatectomy with the colorectal resection. And I think this is really a wonderful option for locally advanced mid or distal rectal cancer as well. So in conclusion, although the simultaneous approach is convenient, it can be unsafe for patients with undergoing major hepatectomy, patients who have locally advanced rectal cancer, patients who are medically unfit, and in cases of emergent or urgent resections of the primary tumor for cases such as obstruction or perforation, less likely bleeding. Thank you.
Thank you so much indeed, Dr. Shafiq, highly appreciated, and also Dr. Himant for your nice presentation. So we have now heard pros and cons of both approaches, and I have a case, and if we have only very few minutes, I can just present a quick case and then followed by some discussion, and then it can be also open to the floor as well if anybody has got any feedback. So I'm just going to share my screen very quickly. This is a 62-year-old man from Ethiopia, presented. He is fairly well in himself, no past medical history or anything. Basically presented with 2 months history of weight loss and fatigue. He had lost about 15 kilograms of weight in the past 2 months. CT scan showed a large mass at the hepatic flexure with liver metastasis, as you can see on this poor quality image, unfortunately. Colonoscopy showed a large non-obstructing mouse. Biopsy showed adenocarcinoma. All the molecular studies, they were pending at the time of our MDT. CAA 7,466. Hemoglobin 6.7, albumin 3.1. The rest of the liver function, including coagulation, are normal. So, just trying to go forward. There we go. So, Hemant, what is the best imaging modality in this patient in your view? You know, we heard that MRI is probably the best, but there is quite a bit of controversies in terms of really how to stage this patient properly. Do you have any view on that?
Yes, Said, I think MRI is the best in terms of characterization of liver lesions and sometimes for detection of liver lesions that may not be detectable by other means, especially if we use liver-specific contrast such as Primovist or Evovist. But so that is good. It has a very good important role. But as far as from a surgical perspective, for strategies in terms of surgical planning, we need a CT scan with a triple phase contrast enhanced CT. So that is the best for that purpose. Again, in many of these patients, if they have got these extensive disease, then a PET scan is also important to exclude extra hepatic disease before we plan any management strategy.
Perfect. Shafiq, do you have any view on the type of preferred imaging? Do you think that PET scan is increasingly being used in clinic instead of having MRI and CT scan of thorax, perhaps?
So I agree with Dr. Hemant with everything he said. Generally, for cases like this, if we're assuming from the CT scan and the MRI that this patient has isolated liver metastatic disease that's resectable or potentially curable, then I would order a PET scan to rule out extrahepatic disease, which would exclude this patient from curability. If this patient has uncurable or unresectable disease, then I'm not sure I would get a PET scan because I'm not sure what that would add. The data goes both ways for PET scan. There are 2 randomized trials looking at the utility of PET scans for things like for this particular situation. But I would particularly get a PET scan. The other thing is how to best image a patient like this after neoadjuvant chemotherapy and how to assess response. I don't know if you're getting to that later, but
I mean, that is very interesting, especially in some, something like mucinous or signet ring cells. And, especially that is a kind of a radiological nightmare, how to assess response to treatment in mucinous carcinomas. I don't know if any of the colleagues, they have any feedback on that. Okay, maybe not. So I'm just going to get
this patient. You have a very good tumor marker, so that shows you very well the response.
Yes, sure, indeed, in that particular patient. So I'm just going to get into the approach to this particular patient, basically. So, Dr. Shafiq, do you recommend liver resection at the time of colon surgery in this patient or not?
So first of all, we would have to look at the imaging in a tumor board with a radiologist and an HPV surgeon. So again, I'm a colorectal surgeon, so I defer resectability of the liver to the HPV surgeon. So definitely for this patient, if we assume the patient's resectable, it's a patient I would start with a couple of months of chemotherapy, neoadjuvant chemotherapy. First of all, that treats any micrometastatic disease. It challenges the tumor biology, and it'll help shrink the tumor a little, but not too much. And if this patient is healthy, like you're describing, and this is going to be a minor hepatectomy or a right hepatectomy, what generally I would do in a patient with an asymptomatic primary like this, in a healthy patient, is I would let the liver surgeon start. If the hepatectomy is uncomplicated, then I'd proceed with a right colectomy simultaneously in a patient like this.
Perfect. Thank you. Hemant, do you have any feedback on this liver?
No, I think I agree with everything that Dr. Shafiq has said, that this is a patient who will need some degree of chemotherapy first. And then if it is a right hepatectomy with a right-sided colonic tumor, then there is an option to do this at the same time. Again, I agree that we should start with the liver first. And if the liver is uneventful and straightforward, then the colonic surgery can be done at the same time. Otherwise, the colonic surgery can be deferred to a later date.
Sure. So apart from the liver itself, is there any patient's criteria with regard to the selection of the patients? This patient got hemoglobin 6.7, albumin 3.1, and lost about 15 kilogram in weight. Is there anything in terms of patient criteria that we take into account?
Dr. Shafiq, would you like to answer that?
Yeah, so for the anemia, I wouldn't operate on this guy for anemia, because in general it's slow bleeding, and the bleeding usually stops after 1 or 2 cycles of chemotherapy. So I would just either transfuse him if he needs transfusions, or give him iron infusions. Regarding the nutritional status, definitely wouldn't operate on him at the moment. He'd need some nutritional optimization before his surgery, but again, not a reason to resect his cancers because he's malnourished. It's actually the contrary. I'd be careful.
So it is kind of case by case basis, basically. And again, I think we discussed this one in part, but is there anything that you advise, Dr. Hemant, for instance, if this patient's got any extrahepatic lesion?
Yes, it is important to know where this extrahepatic lesion is. If the patient has a lung lesion, which is a solitary lung lesion, then that does not exclude the patient from potential curative options. So therefore, it is important to know that. And if, however, the patient has got multiple metastases elsewhere, then curative option is not for this patient. And then we are looking at palliative options. So it's important to know that.
Perfect. Thank you so much indeed. I think, we are just about out of time, and I really thank you both, Shafiq and Hemant, for this very nice debate, and back to the organizers. Thank you.
Thank you all for this fruitful and very comprehensive presentations, and it opened a lot of points of debates and discussion. And I think what we can summarize is that all options are available, and the patient selection for the suitable line of management is best option, I think. Dr. Amr, want you to...
Yes, I have just before concluding, before the conclusion, just a question for our hepatic surgeon. When we have a colorectal liver metastasis in a case like what we were presented before, anyone perform a routine hilar dissection or hilar lymph node dissection, or if in PET-CT is positive, we resect it. If not, we don't go for a section of hilar lymph node. Dr. Schmidt, if you have any...
Hilar lymph node metastases are very bad prognosticator and have a 5-year survival of less than 5%. So if it's essentially a metastasis of the metastasis showing aggressive biology, so I would be very hesitant. So if I have, if I see on a PET scan or on a conventional scan suspicious hilar lymph nodes in the presence of colorectal metastasis, I would probably advise against resection unless this is a very young and super fit patient who wants to go for everything. But in a normal elderly patient, this is a very bad idea to do it. They almost all die. quickly.
Yes.
Same is true for lung metastasis, by the way. You know, the metastasis of a metastasis is a very bad, aggressive prognostic sign.
I think, Dr. Amr, you are asking regarding prophylactic and lymph node dissection, or?
Yes, exactly. Is it routine, or if we have, do you perform routine hilar dissection if the PET-CT, or if only the PET-CT is positive for hilar lymph node?
Yeah, if there's a suspicion, I would think carefully if to operate this patient. But if I operate them, I would do the lymph node dissection, of course, because if you leave it, then you don't need to do the liver resection. But in the routine case that has liver mets, without suspicion, I don't do routine lymphadenectomy, because it's 1 out of 12. You do 18 to 19 lymphadenectomies to find one metastasis. And I'm afraid that the adding the morbidity is in the overall balance negative for the patient, for most patients.
Last question concerning the bilobar hepatic focal lesions. Do you prefer performing embolization if we have a small left lobe? If we have metastasis in the left side, do you prefer to make clearance of the left side with right portal vein embolization if the patient is surgical? But if now we are presented with, we have patients with bilobar liver metastasis and we have metastasis on the left side. Usually, embolization of the right side, the rate of increase on the metastasis side is higher than the increase in the volume of the left lobe.
Yes.
What's your solution for such debate?
Well, you always have to keep in mind that embolization is giving a growth signal to the other side of the liver. And if you have metastasis present, usually the metastasis is benefiting more from the growth signal than the healthy tissue. So
I think 3 times more the parenchyma increase.
Yeah, so you need to think carefully to do this maneuver if you leave metastasis, if they're very small and you can afford a growth. Sometimes you even get additional metastasis because micrometastasis that had been dormant, they start growing, but that's of course good because then you can select these patients better. But I try to avoid this situation as far as sometimes it's bilobar and we cannot change it, but if it's in some way parenchyma sparing resectable, I would do everything to downstage the tumors. If they are small, put a clip first and then do as little resection as possible. But if you have widespread bilobar metastasis, of course, you need to look at every case individually. It's a very, very difficult to make a generalized statement about this kind of scenario.
Okay.
Professor Amr, can I just comment on this particular question?
Yeah,
Dr.
sure.
Hemant here from Dubai. Yeah. If the left lateral segment, for example, has 1 or 2 lesions, and we want to do a portal vein embolization for the right side, then what sometimes we have done is we have combined the portal vein embolization with a percutaneous microwave ablation of those 1 or 2 lesions in order to try and destroy those lesions so that they don't grow faster than the normal liver.
Yeah. But if we have, and if we have just a few lesions left side, radio frequency for the few lesions followed with right portal vein embolization to stop the growth of the lesion.
Preferably microwave rather than radio frequency, because I think
we have a very nice paper of Dominique Elias who presented the rate of growth of the lesion on the left side for the remnant liver at 3 times the rate of increase in the parenchyma. That's why what you mentioned, I think, is a very good approach. Secondly, I want to congratulate you about the conclusion slide, but I found the debate passes in the same direction, and you and Dr. Shafiq, I think the same ideas and the same conclusion. The conclusion slide in your presentation was really a very nice one. Thank you so much. Dr. Mustafa, if you want to add the conclusion statement.
I have just one question, if you don't mind, Professor Schmidt, or everybody else. Recently, there has been some papers about portal vein plus hepatic vein embolization in order to increase the future liver remnant even better than portal vein embolization alone. Does anyone have any experience about that, and what is your opinion?
We don't use it because first of all, we don't really need portal vein embolization very often. If you do a very good neoadjuvant treatment, I think it's maybe 5 to 10% of the cases where you need it, and in most cases it works. So we are left off with maybe 2 or 3 cases, and then I would check if the embolization was done right. But of course, I have to acknowledge that to do inflow and outflow obstruction might be a little bit more efficient than both. So it's worth a try in the few cases that's not working well.
Thank you.
Thank you all for the nice presentations, the nice discussions, and I think we're out of time. And we have to move to
thank you so much, my dear professors and consultants. It was a very heavy meal for all of the audience and for us. I'd like to thank Professor Yanish Med, Professor Ender Drondo, Professor Volker, and of course Professor Shafi and Professor Hemnet, and of course our great moderator and organizers of the session, Dr. Amr Abal, Dr. Mustafa Shazli, and Dr. Saeed for the nice moderating of the debate. That it was a very nice debate actually. Now we have to move for the next session. Actually, we are a little bit late, about 1 hour from our schedule. So sorry. We tried to condense it. No, it was great. I wish to cancel my session to continue in this fruitful discussion. So
your HIPIC will be a complimentary for the same session.
We have to another session. I believe it will be interesting as well. HIPIC and immunotherapy. Immunotherapy is a very interesting target therapy of colorectal cancer as well. So we'll try to condense it to be in the same timetable. Now we will move to the HIPIC session. I'll be honored to moderate myself and my colleague Professor Anwar this session. Professor Anwar, do you like to introduce our colleague Erdal for his first presentation? And the other panelists, please stay with us, and the other audience, you will hear a lot of debate about the HIPIC and the immunotherapy, and all will benefit from your input, actually. Dr. Anwar, do you like to introduce Professor Erdal?
Good evening, everybody. I'm very happy for inviting me in such a great symposium and very successful, actually, scientific and comprehensive. I would like to thank Prof. Ihab and the organizers for very eminent and very nice, actually, presentation and comprehensive. I would like to introduce one of the eminent gastrointestinal surgeon from Turkey, Prof. Polat. Is completed gastrointestinal surgery after general surgery fellowship, and he's working as gastrointestinal surgeon, and he was working in Cartel Cotiolo Institution Training and Research Hospital 2011, and also he's associate professor 2017, then professor 2021 with the Department of General Surgery and of the University of Health Science. We are very happy to have such a figure, an eminent professor, and he has also 35 articles. He has a special interest in cytoreductive surgery and HIPIC. Please, Professor Polat, mic is yours.
Thank you for kind invitation to organization committee. This was great honor for me. Tonight I will understand and talk about the current status of surgery and hyperthermic intraperitoneal chemotherapy in patients with peritoneal carcinomatosis from the colorectal cancer. Peritoneal metastasis from colorectal cancer still represent a huge healthcare problem. Approximately 5% of colorectal cancer patients present with synchronous peritoneal metastasis, and 6% develop metacarcinous peritoneal metastasis during the disease course. And historically, peritoneal metastasis had been considered as a terminal stage of the disease, and patients were treated with systemic chemotherapy, which may provide approximately 12 months oral survival. Over the past decades, peritoneal metastasis is considered as a locoregional disease because surgery and HIPEC have resulted in 5-year survival rates of 40%. And now let's look at how surgery and HIPEC is considered as the standard treatment for selected patients with colorectal cancer with peritoneal metastasis in the world. As you know, Sugar Baker described the peritoneal cancer index. This index is the most accepted score for both evaluating the tumor burden and estimating the patient prognosis. And it is helpful for surgical decision. And Farron and colleagues showed that 5-year survival rates reduce as peritoneal cancer score increases. Currently, the majority of guidelines accept that peritoneal cancer index higher than 20 as a contraindication for surgery and HIPEC. And what are the absolute exclusion criteria? Diffuse peritoneal metastasis and peritoneal cancer index higher 20 point, undetectable extraperitoneal metastasis, and diffuse small bowel serosal involvement and massive mesenteric involvement, multiple segmental small bowel obstruction and ileus, short remnant small bowel and massive involving the hepatic hilus, and undetectable liver metastasis or necessary for major hepatectomy could lead to insufficient hepatic function. The principle of surgery is to completely remove macroscopic tumors or leave a small residual tumor volume fewer than 2.5 millimeter, which is sufficient for the therapeutic effect of HIPEC. So we always perform embolocarization of involved peritoneum, especially in high peritoneal cancer score, pseudomyxoma, peritoneal mesothelioma, if possible. In this case, you see a small bowel mesentery has a gross tumor involvement in our case. This is not absolute contraindication criteria for our surgery practice. If all involved visceral mesoperitoneum can be stripped, as you hear. And there are gross implants on the diaphragm, so we perform en bloc peritonectomy. And the left and right peritoneomies. And this is en bloc total proctocolectomy and hysterectomy specimen. And this is retroperitoneal para-aortic lymph node dissection for ovarian cancer patient. When there is intensive pelvic peritoneal implant involvement, we recommend to perform embolocarization of pelvic peritone with colorectal cancer, uterus, and invasion of small intestine. If you try the resection of these organs separately, more seeding metastasis occurs as a result, and it will be very difficult. And you see en bloc peritone resection with the other organs and posterior image. And this is an interesting image of ovarian metastasis from colorectal cancer. This is a good indication for hyperthermic intraperitoneal chemotherapy. We must perform complete steroidization. So if there is hepatic breach at the end of the round ligament, we suggest divide the breach for resection of the hidden implant, as you see here. After complete steroidization, we perform HIPEC. Firstly, we fill the abdomen with approximately 4 liter isotonic or dextrose fluid. Then fluid is circulated by a pump while heated up to 42 centigrade. Then we administered chemotherapy drug in the fluid for 30, 19, or 120 minutes as before. And there are two methods for HIPEC. This is an open method, but this is a closed method. 20% of HIPEC centers in USA still use cardiopulmonary bypass machine with a heater as us. And you see here inflow and outflow drains. Various chemotropic various chemotropic drugs are used in the world. But there is two main interperitoneal chemotherapy regimes. Mitomycin C or over 60 or 20 minutes and 42 centigrade. IV infusion of fluorescein and beta-glucuronidase and then 30 minutes later, interperitoneal oxaliplatin administered for over 30 minutes at 42 centigrade. Patients in two groups had similar long-term survivals. There are many comparative studies between oxaliplatin and mitomycin C, but there is no difference. But we must know this PRODIGE 7 study because this is very important, recently reported in France. They did a randomized open label phase 3 trial at 17 cancer centers in France for two groups. One 33 surgery and HIPEC with oxaliplatin, and the other group one 32 surgery and median follow-up 63.8 months. And as a result, overall survival median month was 41.7 for stereotactic surgery and HIPEC group, and 41.2 for stereotactic surgery alone. And the relapse-free survival median month was for approximately 1 year for both of the groups, and no significant difference between the groups. And however, subgroup analysis for the patients, peritoneal cancer between 11 and 15 showed significantly much better overall and recurrence-free survival for the HIPEC group. In this review, analyzed the survival rates of the studies. As you see, in the last 5 years, the median disease-free survival is approximately 1 year, and median overall survival 33 to 60 months, and major morbidity range from 14.7% to 47.2%, and mortality range from 0 to 5%. Although our results at Turkey University of Health Sciences, Kocaeli Hospital, we performed stereotactic surgery and HIPEC for 120 patients in between 2018 and 2021. Colorectal cancer patients number is 67, and pseudoxanthoma peritoneal is 19. And the median age of our patient is 56. Although some centers accept over 70 years of age as a contraindication, but it can be performed for older patients with low peritoneal cancer index at experienced centers. And the median body mass index of our patients is 26, Although some centers accept morbid obesity is a contraindication, a relative contraindication, but it can be performed for morbid obese patients with low peritoneal cancer index at experienced centers too. And our median operation time is 7 hours. I never forget that one day while we were performing surgery and HIPEC during 12 hours, a heart transplant and then a lung transplant operation completed at next operation room. And our median hospitalization day is 11, but one patient who developed intestinal fistula stayed at hospital for 77 days. Our median intensive care unit day is only one. This is a good result, is the success of our anesthesiologists for the intraoperative management. We performed prophylactic HIPEC for 34 patients, and the other 95 patients median peritoneal cancer index was 6. As you see, surgery and HIPEC can be performed to mesothelioma and to the myxoma patients with over 20 peritoneal cancer index score. Our morbidity rate is 63.6%, but major morbidity rate is 24.8%, as similar as the other studies. And most morbidity is wound infection. 30-day mortality rate is only 1.6%. 2 patients died because of sepsis due to colorectal and esophageal anastomotic leak. Recurrence was observed in 42 patients, and median disease-free survival is 11.5 months, as similar as the other studies. As a result, surgery and HIPEC can provide 41 months median overall survival for peritoneal metastasis from colorectal cancer, and I hope better results in the near future with the support of molecular medicine studies. Thank you for your attention.
Thank you very much, Professor Polat, for very comprehensive, excellent presentation, actually. Because of the time issue, I will move directly to our next figure, eminent surgeon, Prof. Ihab. I think all of us know him. He is Assistant Professor of Surgical Oncology, Cairo University, and Head of Department and Consultant of Surgery at Saudi German Hospital, Jeddah. Without any further delay, I would like to introduce him. We are happy to have you, Prof. Ihab. Please, your mic.
Thank you so much, Professor Anwar, for the nice introduction. Professor Erdel, could you stop sharing your presentation?
Oh, sorry.
It was a very nice presentation, Professor Erdel. I like it a lot. Actually, we have a common thing, which is both of us are fans of HIPEC. I need to share the other one. Can you see my screen now?
Yes, clearly.
Okay, for the sake of the time, I'll try to be as fast as I could. I'll try to address the issue of the subject of prophylactic HIPEC. Dr. Erdel perfectly addressed the issue of therapeutic HIPEC, but I'll try to take it from the other issue, which is prophylactic HIPEC. As we all know, colorectal cancer is a major problem worldwide. It represents about 2 million cases per year, the second and the third most common cancer in women and female and male, respectively. From 20 to 25% of the patient already have a distant metastasis at the time of the presentation, while 18% or 19% have metachronous metastasis. From 10 to 35% of the patient have a recurrent peritoneal metastasis confined to the peritoneal cavity with no ever distant metastasis. And usually those patients unfortunately die from the local original tumor complication rather than from the distant metastasis. According to the AJCC TNM classification, peritoneal metastasis or carcinomatosis with from a colorectal cancer is assigned at the worst prognosis, stage 4C. So how to manage peritoneal carcinomatosis from colorectal cancer? All of us are aware about National Comprehensive Cancer Network that was yearly published. According to the recommendation of NCCN 2021, they are not in favor with an aggressive management of such kind of the disease. And they stated very clearly, if you have a synchronous abdominal peritoneal metastasis, if it was non-obstructing, you have to go directly for palliative chemotherapy. Either the protocol will depend, either the patient is fit or not fit for chemotherapy. And they concluded that the patient with peritoneal metastasis from colorectal cancer usually have a shorter disease-free survival and overall survival. And the goal of the treatment in such condition should be palliative rather than curative. They don't see that the curative, and they don't have a data that the curative ended for such kind of the disease will affect the prognosis of the patient. But even when we revise the palliative systemic therapy, even when they were treated with modern chemotherapy, modern target chemotherapy, survival is still very great. We have a patient with peritoneal carcinomatosis according to a study published about using a palliative targeted chemotherapy. Over 2,000 patients, we found that the patient with peritoneal carcinomatosis have a median overall survival 12 months versus without peritoneal carcinomatosis up to 18 months. And we, from another retrospective study of about 4,000 patients, they concluded that the biological aggressiveness nature of the peritoneal carcinomatosis that might affect the patient, high-risk patient, actually impair the functional status of the patient to the extent that make them eligible only for palliative chemotherapy. And from those 4,000 patients, we found 12% of them have a peritoneal carcinomatosis, and the median survival for those patients with peritoneal carcinomatosis was from 7 to just 18 months, which is totally different from other patients without peritoneal carcinomatosis, which reached up to 20 months. Going back to the recommendation of NCCN, if you have we finalize the non-obstructing, if you have obstructing lesion, they just, with a very conservative issue, they recommend to have either a colonic resection or diverting stoma or just bypass. And at the end of their recommendations, they stated very conservatively that if you could achieve R0 resection in a single peritoneal metastasis, the patient might be benefit from aggressive cytoreductive surgery with or without hyperthermic intraperitoneal chemotherapy. That's why there was an urgent need for randomized trials. All of the surgeons know well how the randomized trial is very difficult to be implemented in a surgical field. But until this date, only 4 randomized controlled trial was published to treat or to assess the impact of the cytoreductive surgery and the HIPEC over the patient with peritoneal metastasis from colorectal cancer. Unfortunately, none of them provide definitive results. The first one was the very famous randomized control trial that was published in 2008. It's an Eric Verwell trial. He randomized the patient either to receive a cytoreductive surgery plus HIPEC, then a systemic chemotherapy in the form of 5-fluorouracil or to systemic chemotherapy, those patients with peritoneal carcinomatosis, of course. And he found that 2-year survival rate was 43% in HIPEC group and 16% in control group. But unfortunately, once this trial was published, it was faced by a lot of critics. One of them that the morbidity was very high in the HIPEC group, up to 8% mortality. The second was a long-term survival after 5 years there was no big difference between the study and the control group. Also, this trial does not include a modern systemic target therapy like oxaliplatin or irinotecan in the control group. About 30% of the patient, including in the control group, in the study group, was of appendiceal origin. And all of us know that the metastasis from appendiceal origin behave much more better than from a colorectal origin. Finally, in this study, the HIPEC element was not studied well because we combined HIPEC plus surgery plus systemic chemotherapy versus just systemic chemotherapy. Then the other famous Project 7 trial, the result was published just 2 years in the last ASCO 2018. I believe Professor Rajdal gave a hint about it, but all of the HIPIC community was in a passion to hear about the result of this trial. It was a phase 3 trial evaluating the role of HIPIC with maximum site reduction in epithelial carcinomatosis from a colorectal origin. They randomized the patient with after complete with a peritoneal carcinomatosis after doing complete site reduction, either to have a HIPIC with oxaliplatin only for 30 minutes, plus systemic chemotherapy, or with just a HIPIC. Then systemic chemotherapy. The primary endpoint was peritoneal carcinomatosis recurrence after 18 months in the HIPIC group and non-HIPIC group. But unfortunately, the result was totally disappointing. There was no significant difference between survival in both groups. In the HIPIC group, 41 months. In the non-HIPIC group, 41 months. Also, in the disease-free survival, there was no significant difference between 11 months and 13 months. But they found in the subgroup analysis that a patient with PC from 9 to 15 might benefit from this kind of approach. Of course, when this trial was published, all of the HIPIC community was totally disappointed, and actually it faced also by a lot of critics from the HIPIC fan in the world regarding to the randomization of the patient, regarding using oxaliplatin. Oxaliplatin is not the best option for a colorectal metastasis peritoneal disease. Regarding the timing of using a HIPIC, 30 minutes was much more lower than expected. Anyway, they proceeded to the conclusion that every patient with HIPIC should offer a complete site reduction, because they found the site reduction per se improve the patient survival from 18 months to 41 months, 43 months. And they concluded that oxaliplatin is not the best option to be used for patients with peritoneal carcinomatosis from colorectal cancer, but it might be benefit for those patients with PCI from 11 to 15. On the other hand, the French guideline is still in favor that every patient with peritoneal carcinomatosis should have a site reduction surgery and the HIPIC. This is based on the most famous published papers from Elias and Franco, Elias Ital and Franco Ital. Elias studied in the form of the retrospective study. He found that the HIPIC group might benefit, HIPIC and site reductive groups, 5-year survival rate reaching up to 62 months versus 24 months for non-HIPIC group. And Franco Ital found that the HIPIC group median overall survival may reach to 35 months versus 17 months. So until this moment, the French are very fan and are very encouraging for the HIPIC and site reductive, provided the two major trials that actually for the treatment or prophylactic was from the French Institute, either Project 7 or Profellowship, that we will talk about it. Both result was disappointing, but they still in favoring and encouraging site reductive surgery and the HIPIC. So as we see, there is no standard and consensus standard of the treatment of the patient that develop peritoneal carcinomatosis. What if we try to prevent the development of peritoneal carcinomatosis, especially in patients with a high risk to develop this kind of high morbidity disease? So from this point, there was an idea, why not to use a HIPIC as a prophylaxis, as an adjuvant? Do we need an adjuvant, a HIPIC, for a patient with a colorectal high-risk condition? Risk of peritoneal carcinomatosis with a patient with colorectal cancer, we have 6 categories of this patient. If you have a patient with resected minimal microscopic disease or isolated ovarian metastasis at the time of surgery, or perforated tumor, or positive peritoneal cytology, or the pathology was a mucinous or single ring, or you have a serosal involvement of the adjacent organ, all of these patients most probably will develop peritoneal carcinomatosis in their follow-up. So let's talk about adjuvant HIPIC. We have 2 major trials in the world that address the issue of prophylactic HIPIC. One a French trial, a Profellowship trial, and the other Dutch trial, which is a Kolbeck trial. And I'm honored to be a part of our institute, our national pilot study in National Cancer Institute to address the same issue, the role of prophylactic HIPEC in high-risk patients. To start first with the Profiloshift trial, it was a phase 3 as well, French trial, including 18 French centers. It aimed at evaluation of the potential benefit of the second look surgery followed by HIPEC in a patient operated on a colorectal cancer at a high risk of peritoneal metastasis. They defined the high-risk patient, those patients with a minimal peritoneal carcinomatosis, resected or ovarian metastasis or perforated tumor. All of these patients, after the primary surgery, they send them for adjuvant chemotherapy. Then with a follow-up to if there was no sign of recurrence, with a follow-up of no symptom, no serosal tumor marker, and CT scan was negative, they randomized the patient either for surveillance or for surgery plus HIPEC. But again, the result was unfortunately disappointing. They enrolled about 150 patients were recruited and randomly assigned in the treatment group. The median follow-up was 50 months, year disease-free survival was 53 in the surveillance group, and surprisingly, it was 44 in the study group. There was no treatment-related deaths in both groups, only grade 3 and 4 complication in the form of intraperitoneal hemorrhage, leakage, but none of them will lead to death. Once they published this result in 2019 as well, I like this title. Does it really save lives? Does adjuvant or prophylactic HIPEC save lives? And they concluded that systemic chemotherapy, also the oxaliplatin, didn't improve disease-free survival, and essentially the surveillance of the patient with high risk is the most important than taking those patients for adjuvant HIPEC. But still, this trial have a lot of critics, and I'll discuss it at the end of presenting the adjuvant trials in the world. The second trial, which is COLPIC trial, it's a Dutch trial. It addressing the adjuvant hyperthermic intraperitoneal chemotherapy in patients with colonic cancer at a high risk peritoneal carcinomatosis. They choose to have to identify only 2 risk factors, those patients with T4 colonic cancer or a patient with intra-abdominally perforated colonic cancer. And they randomized patient either early adjuvant HIPEC using oxaliplatin during the colonic surgery or within an interval not less than 10 days or after 5 to 8 weeks from the primary surgery. The primary endpoint was to detect peritoneal recurrence within 18 months by CT or laparoscopy. And they randomized the patient into 2 groups, either to receive adjuvant HIPEC, adjuvant for the second look according to the timing of the second look operation, or just to receive a systemic chemotherapy. And again, the result was not disappointing as well. There was no difference in the peritoneal-free survival 18 months, 77 for a control group and 81 for experimental group. And they concluded that this HIPEC approach or prophylactic HIPEC with oxaliplatin does not improve the peritoneal metastasis-free survival at 18 months, and it shouldn't be recommended as a routine use for a patient with high risk to develop HIPEC. Now, this is our pilot study that we already did in our institute in Cairo University. It addressed the prophylactic HIPEC in colonic cancer with a minimal serosal involvement. The main issue is to evaluate the visibility. We started this about 2000, at the end of the 2017, even beginning of 2018. The aim of the study is to study the effectiveness of adjuvant HIPEC in preventing the development of peritoneal carcinomatosis in colorectal cancer patients after colectomy, and the primary endpoint is the peritoneal recurrence within 18 months. Now we included all patients who have a risk factor to develop a peritoneal carcinomatosis following a colectomy. Those patients with T4 or minimal peritoneal carcinomatosis or ovarian metastasis or ruptured or heterogenic rupture. Even if heterogenic rupture during surgery, we included them in our trial. We excluded patients over 65 with metastatic disease with performance more than 2. We randomized the patient. It was a pilot study, so the number was a little bit low. 21 patient was randomized, 11 patient 1-to-1, 11 patient in the experimental group and the other patient in the standard group, and we followed up them up to 18 months using a CT scan and the tumor marker. Demographic was not demographic of the patient. This is the demographic of the patient presented in our group. Based on the radiological finding of those patients before operation, we included them in our trial. We have a radiological finding that prove that those patients have a risk to develop peritoneal carcinomatosis, either neural thickening or infiltrating the surrounding, or a presence of bulky mass with an adnexal mass. Intraoperatively, we completed 3 patients with laparoscopy, and the other patient was completed with open technique. We found the same, more or less the same finding of the preoperative assessment of the extension of the lesion. We had a difference between left hemicolectomy and anterior resection, right hemicolectomy, sigmoidectomy, and this is a figure of each one of the procedure. And we have additional resection was performed in 16 out of 21 patients in the form of partial cystectomy, small bowel resection, and another limited peritoneal resection in 4 patients. Fortunately, we didn't have any mortality in the study group, only one morbidity. It was in the form of deep bone infection that was managed conservatively. The median length of stay in the hospital was mostly equal between both groups. The pathological assessment, 10 specimens were classified as T3, while 11 specimens were classified T4 and T4B. All patients received adjuvant FOLFOX with a commenced or started immediately within 4 weeks from the date of the surgical procedure in 17 patients, and only in 4 patients was delayed beyond 4 weeks. 2 of them was because of the treatment of progression, and 2 of them was because of the treatment-related toxicity, and the other 2 was because of progression of the disease. We have a survival rate and the disease-free survival in the HYPIC group 17 months and in the control group 12 months, with the cumulative reached up to 50% in the HYPIC group and 12% in the control group. We have two variable, very specific variables that indicate the recurrence of the disease post-operatively, which was a tumor marker and the extent of the nodal disease. As we see here, that whenever we have a nodal disease up to N2, the survival rate was extremely low than N0. The only variable, all of both groups has the same variable regarding demographic, clinical presentation, preoperative results, operative details. The only variable that differed between the 2 groups was statistically significant was the nodal capsular and perinodal infiltration. Regarding our study, although our p-value because of the number was not significant, but it did succeed to prolong the time of the survival in the HYPIC group up to 17 months, and in the non-HYPIC group regarding or comparing to the non-HYPIC group, which is 12 months. In addition, in the HYPIC group, there was a high incidence of nodal capsular infiltration, which affects the survival in the HYPIC group, and we cannot standardize this item because it's only detected post-operatively in the pathological assessment. If we put the 3 trials together, the Profiloscope and the Colpic and our trial, the Profiloscope and the Colpic trial, the result was unsatisfactory and was thus disappointing. But if we are went in the depths of the analysis of this trial, both of them, there was a suboptimal design of post-trial, and both of them insisting to use oxaliplatin. As we stated before, oxaliplatin is not the perfect choice for a peritoneal carcinomatosis from colorectal cancer. Actually, this has been described by Wentzelin as being the end of the road for oxaliplatin. Also, in both Colpic and Profiloscope, they have an interval between the primary surgery and the second surgery, and this interval, from our opinion, it affects the result of introducing a HYPIC, because the oncological benefit of performing simultaneous HYPIC as opposed to the interval HYPIC is demonstrated well by our understanding to the pathophysiology of peritoneal carcinomatosis, because most of the exfoliations of the cancer cells during surgical manipulation in the first step is the first step of the spread of peritoneal carcinomatosis. Another drawback of delaying adjuvant HIPEC to interval HIPEC is the delay of the systemic chemotherapy. And all of us know that delaying systemic chemotherapy will affect greatly the extent of the overall survival and disease-free survival, and this was proven by a lot of multi-center trials. The last thing about the post-trial, they were not inconsistent with the patient selection. They choose a specific risk factor and they drop the other risk factor, which might cause the standardization of the patient in a control and study group biased. And this is where stated by Sugar Picker himself, where he said where inconsistent selection criteria, where their high-risk population were not accurately defined before proposing such an invasive approach that may place the patient in a worse condition. So that's why in the community of HIPEC now, all of the community are working on what we are calling a peritoneal recurrence score. It will be like a peritoneal carcinomatosis index, and this score will help the future trial to accurately allocate the patient with a high risk in such kind of trial. Using this peritoneal recurrence score will help a lot in the future trial, and I believe from my side, it will reflect on the result. So the other thing that we try to overcome in our trial versus the Colbeck and Profili trial, we use a mitomycin rather than oxaliplatin, and we use that for 19 minutes, not only 30 minutes. Finally, the take-home message, as I stated in the first of my talk, I'm one of the fan of the HIPEC. I'm one of the surgeons that push the HIPEC. I believe that the HIPEC might help a lot of people with this kind of aggressive disease. So the magnitude of the morbidity and suffering of the patient with peritoneal carcinomatosis, in addition to the financial burden, we have to consider both of these items. We shouldn't stop at the disappointing result of the two largest group trial, Colbeck and Profili. We should push for another trial to get to standardize and to put it in a nice and correct way to have another result. The second thing, to be able to make a reliable statement regarding the oncological effectiveness of adjuvant HIPEC, we need to implement a full-scale randomized control trial, not less than 160 patients in every arm. In addition, we need to consider the Dutch recommendation of a high-dose mitomycin that might be beneficial for those patients. Finally, we believe that if the study design is implemented in a correct way, the result will be totally different. And finally, I'd like to finish my presentation with a quote from Sugar Picker. He's the godfather of the HIPEC worldwide. This quote from his last hard book from the hardcover of his last book. He stated that peritoneal metastasis, when primarily treated, can be cured in selected patients, and peritoneal metastasis can be prevented. Thank you so much, and sorry for taking much time that I promised. Thank you, Dr. Anwar. Thank you, Dr. Erdel, and thank you for the panelists. I believe we're still out of time and we need to move to the next presentation. Next presentation is presented by my colleague and my friend, Dr. Anwar. Dr. Anwar, one of the eminent guy working in this field of medical oncologist and the fellowship medical oncology. He had an experience with the radiation, Isotope Center in Sudan, King Fahd Medical City in KSA. Currently, he's working as a consultant medical oncology at SGH Riyadh. Go ahead, my friend.
Thank you very much, Prof. Ihab. Thank you for a great presentation. My talk will be about optimization of the outcome regarding the metastatic colorectal cancer. And I will not speak about the details of many trials. I will go only for the meta-analysis results. Sorry. Yeah. As you know, this is the colorectal cancer is the third most commonly diagnosed worldwide and the second cause of death among cancer. But still, the metastatic disease with a major cause of cancer-related mortality, still the overall survival can reach up to more than 30 months. Next slide. I'll concentrate about the current state of art in the systemic therapy of resectable advanced colorectal cancer, and also will mention few words about the tumor sidedness and molecular pathology and non-actionable targeted, and a few words about oligometastatic advanced colorectal cancer. So as we know, the ideal multidisciplinary team should contain medical oncologists, radiation oncologists, colorectal surgeon, specialist, hepatobiliary lung surgeon, pathologist, molecular pathologist, biologist, and diagnostic radiologist, and of course, the interventional radiologist and nuclear medicine physician. Next. So evolving the continuum of care in the first line treatment, we should consider the patient characteristic, tumor characteristic, and the treatment goal. And the second step is the maintenance therapy. This will optimize the benefit actually in the first line, and we'll go for in the second line, we should consider the patient characteristic and activity of disease, and actually all the time we should consider the molecular biology of the tumor. We have three characteristics should be considered when choosing the systemic therapy. First of all, the tumor characteristic, which contain the clinical presentation, tumor burden, biology, and of course for the RAS mutation status, BRAF, MSI, tract, and HER2 status recently approved. For the patient characteristic, we need to know the age. Previous slide, please. The age and performance status and the comorbidities. Regarding the treatment characteristic, we will have to we'll have to address the code actually, address the why we are using this treatment in the first and second line, what is the aim and flexibility, and of course we should always putting socioeconomic factor in consideration with the quality of life for the patient. Next, please. Left side versus the right-sided tumor. This has been addressed in the last 10 years. Doublet chemotherapy accompanied with anti-EGFR inhibitor for the left side in the RAS and BRAF wild type. In the mutant, we cannot use the anti-EGFR because they have experimental effect. According to the recent studies, doublet and BEVA is the treatment of the RAS mutant. For the BRAF mutation, we have the doublet or triplet. There will be no big difference between the two in combination with bevacizumab. Next, please. When we could look at the combination versus sequential, because some people think that sequential can have less toxicity and will affect the survival. It is not the case because combination strategy outperforms the sequential treatment regarding the response rate and the PFS. There's still no significant difference in the overall survival and toxicity rate. Next, please. The efficacy of adding BEVA plus the chemotherapy in the metastatic colorectal cancer regarding the meta-analysis, in spite of there is improvement in the progression-free survival and overall survival, there was no proven PFS overall survival in adding bevacizumab to the oxaliplatin containing region. Next. When you look at the GFR in the KRAS wild colorectal cancer, and we have two agents, anti-GFR, cetuximab and blinatumab, usually used in this setting, and both of them will carry improvement in the progression-free survival and improve the overall survival. Next. The recommendation for RAS, as we know, the KRAS activation will be detected almost in 40% of metastatic colorectal cancer. And evidence of a 3 trials suggests the detrimental effect when used in the case of RAS mutant disease, especially when combined with oxaliplatin-based cytotoxic. Next, please. Regarding the BRAF mutation, still there is no additional benefit from the EGFR inhibitor in such cases, but standard of care is the anti-BRAF inhibitors. Next. BRAF mutation, we can find it in 8 to 11 to 12% of patients in metastatic colorectal cancer, and usually the usual type is V600E, and almost exclusively non-overlapping with the KRAS mutation. 2/3 of the patients will be located in the right side of the colon, and 1/3 will be MSI, instability. BRAF mutation should be assessed along wise, assessment of tumor RAS mutation, and also for the patient characteristic and mutation. Next, please. Regarding significant about the prognostic significant regarding the BRAF, it is definitely a negative prognostic marker. We'll see the difference in median overall survival will be decreased from 34 to 10.4 only in patient with RAS wild type. So the response to anti-GFR is unlikely with the patient of RAS wild type. We have two meta-analyses showing the efficacy of benefit of anti-GFR greater than the RAS wild type, than the RAS wild type mutation tumor. And also the recent data provide evidence no increased benefit from the use of triplet chemotherapy with BEVA as first line. There is now evidence there is a resistance to anti-GFR monoclonal antibody in such patients, which are the mutated BRAF patient, and this will be overcome definitely by the BRAF inhibitors. Next, please. 1/5 of the all RAF patient will have the atypical mutation, which is non-B600E, and in such cases present a distinct subgroup regarding the gender, tumor location, metastasis, and side status. Still, the anti-GFR need more actually further investigation in such type of patient. Next, please. So the question usually the BEVA versus panitumab in the first line, there is in the meta-analysis no significant difference found regarding the overall response rate or the survival benefit or adverse. You see the multiple trials here comparing the EGFR inhibitor and compared to the arm of BEVA. So chemo BEVA versus chemo anti-GFR, and the only significant was when the tumor on the left side, as we see in the red color at the bottom, the significant p-value when adding the anti-GFR in the left-sided tumor. Next. Multiple trials also meta-analysis study regarding irinotecan, 5-FU, capecitabine with the BEVA, and it will compare here the intermittent versus continuous. Next, please. The conclusion for the intermittent strategy of first-line systemic therapy do not result in the reduction of overall survival or improve the quality of life. So both of them are options. Next. For the patient receiving FOLFOX, CABOX, BEVA, will consider the maintenance after 6 to 8 cycle, and overall survival not being improved with the maintenance strategy. Treatment holiday is valid option in many patients. When you use FOLFIRI, actually, we will continue until shrinkage of tumor or toxicity. For patients with single 5-FU BEVA will continue the same. The maintenance of panitumab, actually, it was inferior in combination with panitumab 5-FU, unlike the cetuximab, because it increased the progression-free survival and non-inferior in continuation of doublet chemotherapy. That the end point here is the BEVA as monotherapy is not recommended as maintenance therapy. Next, please. For the second line, the initial therapy, if you use the oxaliplatin-based regimen in the first line, we use the irinotecan-based, and actually we can continue the BEVA beyond progression, or we went to another anti-EGFR, which is the anti-aflibercept. Ramucirumab also it has been approved with combination of FOLFIRI in the second line setting, EGFR antibody, as we mentioned, and usually all the time you should consider the molecular profile of the tumor. Next. This is only to mention when you add aflibercept to FOLFIRI, it's a good option in the second line treatment if you use the BEVA in the first line. It shows the survival benefit. Next, please. And this is the standard study for ramucirumab, FOLFIRI in the RAISE trial. It shows almost 3 months difference or more than 3 months difference between the two arms. For the anti-BRAF therapy, we have the Beacon standard encorafenib plus cetuximab plus or minus pinitinib. For the BRAF V600E mutant metastatic colorectal cancer. Next. We'll see both if you use the triplet or the doublet. Both of them will have a nice separation, survival benefit, almost more than 4 months between the two arms. So anti-BRAF is the treatment of choice in the BRAF mutant patient. Next. For the standard, beyond the second line, we have two agents approved, known to us, regorafenib, which is Tivagia, and the TAS-102, which is trifluridine in combination with the Ibracil for such patient as a third line. Still, as we mentioned before, consider molecular profile, immunotherapy for MMR deficient, MSI, high tumors, BRAF inhibitor for BRAF mutant patient, and recently we used to use the anti-HER2 target therapy for HER2 overexpression tumor. Next, please. So this is also the standard study for the Rigoras, Tivargia versus the placebo and the control arm. Almost 2 months difference, correct study. Next. Also the TAS-102 as a third line gives almost 2 months difference survival benefit between the two arms. Next. As you mentioned, the genetic profile is very important in all patients of metastatic colorectal cancer. From the start, we should have a KRAS, NRAS status, BRAF, NTRK1, HER2, and PIK3C, and ATM, MET, AKT1, and RET oncogene. Next. For the primary tumor sidedness, we all know that there is a big difference between the right-sided tumor and left-sided tumor. For the wild type, recent data suggests the sidedness of primary tumor may be prognostic and predictive significant. For the right-side tumor, associated with inferior outcome, and we will have some association between the MMR status, BRAF status, for the associated right-sided primaries. Next. So when you there are 66 studies in the meta-analysis compared the left-sided versus the right-sided, and shows that left-sided primary tumor associated with significant 20% reduction of risk in the left side. For the molecular aberration metastatic cancer, as we mentioned before, we need to check all molecular status. I will not go into details of that. It should be a next generation sequence panel. We'll have all the picture if we make it as a routine. So regarding MSI, you have 4 to 8% of tumor, which has the metastatic colorectal cancer MSI due to deficiency of MMR system. And the third of the tumor exhibit also BRAF mutant. So it is negative prognostic marker for regarding the survival benefit in metastatic setting, but it's still also negative for the response to chemotherapy. But recent data, however, suggests MSI is a positive predictive marker regarding the response to immunotherapy. And consequently, MSI testing is recommended in all patients with metastatic colorectal cancer with the genetic counseling and predictive value of the use of immune checkpoint inhibitors. Next. Regarding PD-L1 blockage, as you mentioned, it started with Pembro phase 2 and the refractory malignancies shows a survival benefit, clearly and a durable response. Next. The standard, next please. The standard study is Keynote 177. I will not go to detail with that. I'm sure my colleagues will go on that in the next session. So it is having next please. We'll see the graph now. If we see there is a nice separation when we compare the Pembro in the Keynote 177 to versus chemo, almost doubling the median overall survival. We will see the also note the cross and the curve indicates the subgroup that they are primary resistant to immunotherapy from the start. Nowadays, the nivolumab plus IBI, and these are studying now in the phase 3 trial currently, it shows a durable response and a great benefit when combined nivo to ipilimumab. And right side, the orange color is the combination nivo and ipi. And now they are studying the low dose ipilimumab because of the toxicity. In spite of that, the combination gives 80% of patients have a reduction in the tumor burden from the baseline compared to the one on the left in the blue color, which is only the nivolumab as monotherapy. Recently, they are studying thoroughly the HER2 overexpression and the variants. The standard study is the Hercules study. Patient with KRAS exon 2 wild type, they harbor 5% will harbor amplification overexpression. Next, please. HER2 overexpression is 5% colorectal cancer. And nowadays, to date, we have many combinations: trastuzumab, lapatinib, trastuzumab, bertuzumab, or trastuzumab deruxtecan as investigation for HER2 overexpression metastatic colorectal cancer. For untracked, we all know that nowadays we are testing that for most of the patient metastatic colorectal cancer as a routine investigation. 1% of metastatic colorectal cancer. We have 2 agents approved, larotrectinib and entrectinib. So as you mentioned, these are the biomarker used and the treatment for that. Next. A few words about the oligometastatic disease, very thoroughly actually mentioned by my colleagues. It is evaluation should be after using the systemic therapy, and the best actually systemic treatment evaluation will be after 8 weeks, and we will achieve the best response. And the aim is R0 resection or the local ablative therapy. Next. Absolute or relative contraindication, as mentioned also, when there is impossibly R0 resection or more than or 30% of liver remnant or presence of a resectable extrahepatic disease. And these are the technical criteria. For relative 1 R0 resection, possibly only complex procedure or R1 section. For the oncological criteria, we have the concomitant extrahepatic disease and resectable or number more than 5 lesions or tumor progression. Next. For the liver metastasis, we'll not go in details. We need to assess the patient in 2 months after systemic therapy, then another assessment in 4 months. In spite of the maximization of the using of conversion therapy, in other words, we're converting the patient from metastatic to radical aim of a treatment. In spite of that, up to 75% will suffer relapse in the future. So we are using the doublet of 5-FU or darbepoetin or 5-FU with the irinotecan, and there is no evidence that there is difference between the two. Usually and all the time, you should be aware of the chemotherapy-associated liver injury, and no clear-cut evidence underlying the benefit of adding biological therapy in this setting. Next. As a conclusion, last slide, survival of patients with metastatic colorectal cancer can be optimized via the integration of systemic therapy, surgical selection, ablative modalities, and most important is the multidisciplinary team setting. Inside the biology of the disease and biomarkers, therapeutic agent expected to improve the survival and rationalize the therapeutic approach, and basic transitional cancer research leading to well-defined hypotheses that are going to be tested appropriately stratified and molecularly enriched clinical trials is the way forward. Thank you very much, and sorry for being a long time.
Thank you so much, Dr. Anwar. It was a very nice and very light presentation. You know, whenever you are start to talk about target therapies, the surgeons start to move scale.
Yeah, I want to build the audience from surgical pictures.
But it was a very nice and very light. I'd like to thank Professor Erdel, Professor Anwar. I have received a lot of questions for you both, but unfortunately, for the sake of the time, we need to move. I have a lot of questions for you, Professor Erdel, but fortunately, if we have a time at the end of the next session, we can discuss it together about the HIPEC and the future of the HIPEC in the world. Thank you so much. We need to move to the next session. We still delayed for our timetable. I'll leave the floor now for Professor Ihab Nakouri and Professor Saeed to take over the last but not least session, and it will be the most fruitful session, as I believe always the good and the excellent and the fruitful thing come at the end of the day. The floor is yours, professors. Dr. Ihab Nakouri, your mic is muted. Dr. Saeed.
Okay. Assalamu alaikum, everybody. I'm really having the great pleasure to be with you tonight. Again, pleasure to have all of you at the end of the session. I hope everybody is awake. I hope everybody is ready to revise this hot topic for the targeted therapy. I think it's one of the struggling and striking issues in oncology in general and in colorectal cancer specifically. So I will leave the mic for my colleague, Professor Dr. Saeed, to lead the session for the time being the first speaker. So Dr. Saeed, please, the mic is yours.
Professor
And
Nakouri,
let me,
thank you
during
so
your
much
introduction,
indeed.
I will share my screen.
Yes, thank you so very much indeed, Professor Nakouri, and all our colleagues in the previous session. And we are very much pleased to open this discussion on chemotherapy and immunotherapy, targeted therapy in colorectal cancer. There is a little bit of a change of schedule. I think Professor Nakouri is going to go first and educate us about the biology of colon cancer, followed by Professor Faisal, who is going to basically educate us with regard to the treatment of different biology of colorectal cancer, and I will touch upon the immunotherapy, followed by the rest of our colleagues. So with further ado, I'm going to present Professor Nakouri, who is the head of Department of Oncology at Saudi German Hospital, Jeddah. And it's a great pleasure to have you on board. And yes, please let us to be educated regarding the biology of the colorectal cancer.
So my topic today focused upon the colorectal cancer is not one disease, and trying to look for the optimal choice of first-line treatment for RAS wild-type metastatic colorectal cancer, with a specific focus and highlighting upon the tumor location and the choice of treatment. I have no conflict of interest. Epidemiologically speaking, colorectal cancer is considered a top threat of death all over the world. It ranked number 2 in Saudi Arabia after breast cancer. In males, it ranked number 1, and in females, it ranked between 2nd and 3rd malignancies after breast and thyroid. The median age at presentation, 59 years in males and 57 years in females. As you see, around quarter of the cases or little more, whether males or females, presented with metastasis. Globally, there is like a human development index. The variation of the incidence of colorectal cancers and mortality is variable. It depends upon where you are practicing oncology in. For example, there is increasing incidence and mortality have been observed in rapidly transitioning countries like medium and high HDI countries, including those in Baltics, as well as Russia, China, and Brazil. The increasing incidence with concomitant decrease in mortality have been reported in very high HDI countries, including Canada, United Kingdom, Denmark, and Singapore. While there is a decreasing incidence and mortality have been reported in a number of the highest Human Development Index countries, including the United States, Japan, and France. So colon cancer is more than one disease. It's not one disease. It depends upon a lot of factors, including host and the tumor factors, whether right-sided disease affecting young or older or senior patients. It depends again upon different molecular changes and mutations, whether there is microsatellite stable or unstable, the RAS wild type, HER2 amplification, and again the BRAF mutation. So I mean, it's an organ sharing one physiologic function, this fecal conduit, but different biological and different natural course behavior. That's why the current standard of care biomarker for metastatic colorectal cancers, including RAS mutation, it represents up to 50% of the cases. Again, HER2 amplification, the presence of microsatellite instability, and BRAF mutation, while NTRK, NTRK mutation is recently introduced in the literature with the availability of larotrectinib medication that proved highly effective in some malignancies, reaching up to 75% response rate as a second or third line treatment. As you see, the NCCN guidelines based recommendation for these molecular markers, you can ask for RAS mutation, BRAF mutation, microsatellite instability at diagnosis, while the HER2 amplification, you can ask it at first presentation diagnosis or after failure of at least one line of treatment. Because of the rarity of the NTRK fusion, you can ask after failure of at least one line of treatment for this mutation. So again, what's affecting your choice of treatment? According to the patient and the tempo of the disease, associated comorbid condition, previously treated with chemotherapy, and the protocol is the age of the patient, the performance status of the patient. Again, there is some tumor characterizations that specify each patient to another, and from the molecular characteristic, plus, and one important thing is the patient preference. Patients prefer the quality of life, so you have to overweigh the toxicity profile coming from the disease or from your treatment protocol. And more important, don't forget the tumor location. So, excuse me, I just have a bar upstairs. I have to delete what to. Okay. As you see, the colon is biologically and clinical significant difference affecting the primary tumor location. And this has changed the treatment paradigm with cases for metastatic colon cancer. And as you know, the embryologic origin of the colon is dichomatous in origin, where the right side derived from the midgut, the left side derived from the hindgut. So if we just take in depth some biological and some malignant characters of the right-sided versus left-sided tumor. If you see here, the mucinous carcinoma have a predilection to the right side tumor and carries a little bit poorer prognosis, has a detrimental prognostic factor. Again, the molecular markers, we have BRAF mutation have predilection to the right side, and BRAF mutation specifically has poor prognostic factor. However, the BRAF mutation in the presence of MSI has similar prognosis to BRAF wild type. What about the CIMP? The CIMP, this is island methylator phenotype. It's high in the right side while it's low in the left side. Actually, its clinical significance is not yet defined, but I'm just giving it to assure you that there is a biological difference between the right and the left side. Maybe its existence may reflect prognosis later on. Again, there is recent data for the BRAF mutation that carries a poor prognosis, although most common, and even it's not common in colorectal cancer, it represents around 5 to by maximum 10%. However, it makes response to anti-EGFR unlikely, and may make the resistance might be overcome when adding BRAF inhibitor to the medication. Like we'll see later on, addition of encorafenib to anti-EGFR. Let us stop at this important point is the gene expression, where there is what is called a molecular consensus subtype. We have actually 4 molecular subtypes. Subtype 1 representing around 14% of the cases and characterized by the immune response activation, and this carries a good prognosis. While subtype 2, this is the classical, the canonical pathway, have epithelial characterization and some MYC mutation and represent around 37% of the cases, and this carries an intermediate prognosis. Subtype 3, around 13% of the cases, and exhibit or display a metabolic dysregulation and carries an intermediate prognosis, while the worst subtype is molecular subtype 4, and this represent or exhibit transformation epithelial to mesenchymal and characterized by invasion, vascular invasion, and angiogenesis, and represent around 23%. The remaining 13% is mixed between these subtypes. So, what is the clinical significance of stratification of colon cancer into these molecular subtypes? As you see, the Australian gastrointestinal trial group, the MAX clinical trial, randomizing patient with unresectable metastatic colorectal cancer to receive first-line treatment, either monotherapy using capecitabine or doublet combination capecitabine and bevacizumab, or triplet combination adding mitomycin to capecitabine and bevacizumab. Their primary endpoint is the population-free survival, while the overall survival was reported as a secondary endpoint. As you see, this trial examined the correlation and the association of molecular subtypes with other molecular and the clinical features used to classify colorectal cancer, including the molecular behavior, including the clinical outcome and treatment outcome in the metastatic setting. And by the way, this molecular subtype, it's a transcriptome-based classification, initially described in early stage colorectal cancer. However, the association of molecular subtype with the treatment outcome in the metastatic setting is yet to be defined and established. As you see, in terms of progression-free survival, the combination was in favor for improving the progression-free survival, whether doublet or triplet treatment versus monotherapy. When it comes to the overall survival, in terms of improvement of the overall survival, it was in favor of the left-sided lesions versus the right-sided lesion, and again, in favor of the combination. What they have concluded in this study is that the molecular subtypes association with treatment molecular subtype 2 and possibly molecular subtype 3 may benefit from adding bevacizumab to first-line capecitabine-based chemotherapy compared with other molecular subtypes. That's why molecular subtype 2 and 3 do intermediate prognosis. That is only reported in this study, but also if we go back to the CLGP SWOG 8045 and the FIRE 3 trials, they concluded that the cetuximab is a part of the most effective combination, representing around 86% for molecular subtype 2, 3, and 4, while bevacizumab was effective in molecular subtype 1. So again, does the anatomical site differ in your selection of treatment? And what's the impact of primary tumor location upon the RAS wild-type metastatic colorectal cancer? By the way, as Professor Anwar mentioned a little before, there is 66 studies to address the importance of the tumor sidedness in colorectal cancer, whether right or left, because it represents poorer or better survival according to the tumor location. As you see here, long time ago, actually, we are talking about 20 years back, since 2001, Manola and Odier reported improvement of the survival for left-sided patients versus the right-sided patients when using 5-FU calcium leucovorin as immunomodulator. They found that the median overall survival 15.5 versus 10.9. Again, as you see along this important studies list, addressing the importance of the left-sided tumor in favor of the improvement of the overall survival versus the right-sided tumor. However, these data, none of these trials, did not compare the vascular endothelial growth factor targeted therapy and EGFR targeted therapy. Bevacizumab versus cetuximab or panitumumab. There are 3 trials, 2 phase 3 trials and 1 phase 2 trial have compared first-line targeted agents, FIRE 3 and CLGP 8045. As you see, they randomized the patient to receive cetuximab with FOLFIRI versus bevacizumab versus FOLFIRI. Again, CLGP randomized the patient to receive FOLFOX or FOLFIRI with cetuximab versus bevacizumab. While the PEAK trial, it was phase 2 trial, randomized the patient to receive panitumumab versus bevacizumab with FOLFOX 6. What they have found, these trials did not meet their primary endpoints, whether FIRE 3 or PEAK trial. They did not reach their primary endpoint that this medication did not improve the overall response rate, while the CLGP did not meet its primary endpoint in improving the overall survival. Again, as you see, the left-sided tumor was in favor of anti-EGFR, while the right-sided tumor was in favor of using bevacizumab. As you see, different clinical trials in the treatment of metastatic colorectal cancers based upon the tumor sidedness described in these trials. And all of these trials confirm the rationale for treatment of patients with left-sided lesions with anti-EGFR in combination with novel chemotherapeutic agents versus bevacizumab in combination with chemotherapy for patients with right-sided tumor. Like you see here, for example, when adding cetuximab, the overall survival was 36 months versus 16.4 months. We are talking about 19 months difference. And this importance and improvement in the overall survival, it was also existing with the bevacizumab, but not pronounced like cetuximab, because of the difference is around 7 months only. If we are talking about phase 3 8045 trial, modifying FOLFOX and FOLFIRI with bevacizumab versus cetuximab, as you see, the primary endpoint, the overall survival, and this trial did not meet its primary endpoint, unfortunately. As you see, the two curves are more or less kissing each other, very close to each other. There was no significant difference between using the cetuximab versus bevacizumab. While if we are talking about the tumor location, when it comes to the tumor location, I mean, so you will find the significant improvement using cetuximab in the left-sided tumor and using bevacizumab for the right-sided tumor. Again, for the FIRE3, it did not meet its primary endpoint, which is the overall response rate, did not improve the overall response rate when using cetuximab versus bevacizumab. But again, when we are talking about the tumor sidedness, there was a difference between those patients receiving cetuximab in the left-sided tumor versus receiving bevacizumab for the right-sided tumor. And when it comes to the tumor location, there is improvement in the overall survival when using cetuximab for the left-sided tumor. Again, we will not leave without talking about the panitumumab using FOLFOX. As you see, there is a lot of trials comparing different targeted agents with chemotherapeutic agents, and at the end of the day, you will find that those receiving targeted therapy plus chemotherapy is doing favorably better when using anti-EGFR in the wild-type tumors for the left-sided colon cancer versus the right-sided tumor. So we are talking about this rationale when using targeted therapy for left-sided or right-sided tumor. It makes a lot of difference. What about the second line and the beyond? We have two trials, 181 and 408. These trials actually using the panitumumab with FOLFIRI alone or in combination. What they have found is that there was a poor prognosis for the right-sided tumor when using panitumumab with the chemotherapy, whether in 181 or 48. So again, when we are using panitumumab versus best supportive care in chemorefractory metastatic colorectal cancer, there is improvement in the progression-free survival only with the left-sided tumor that exhibiting wild-type RAS mutation. And this was applied also for cetuximab versus best supportive care. There was a significant improvement for those patients exhibiting RAS wild type versus mutant type. As you see in this busy slide, the last 15 years have seen a major advances in the treatment of metastatic colorectal cancer. If I'm taking your memory back 20 years, the only and the sole active medication in this session was 5-FU plus or minus leucovorin. And its effect in improving the median overall survival for that patient at that time from 10 to 12 months. However, with the introduction of stronger chemotherapeutic agents, combination, plus targeted therapy, whether tyrosine kinase inhibitor, whether monoclonal antibodies, whether immunotherapy, single or combination, adding another new medication like larotriptide, although it's a rare situation, but improving the overall response, improving the overall situation, and shifting the overall survival from 10, 12 months to 3 to 5 years, reaching up to 20%, which is really big achievement in this issue. And this is the big list of NCCN guidelines recommendation for those patients in the metastatic session, whether left-sided, right-sided, harboring RAS mutation or not, MSI, MSS, and so on. My take-home message today is that the current standard of care biomarkers for metastatic colorectal cancer, including extended RAS, BRAF mutation, exhibiting mismatch repair or microsatellite instability, HER2 amplification. Regarding the NTRK, although it's rare, representing around 1% of the cases, however, with the introduction of larotriptide, that's associated with high response reaching up to 75% in many cancers, including adult and children. So it's worth to ask for that maybe after failure of the second or third line treatment. Again, the best way to combine or to sequence active agents is not yet known. The benefit of monoclonal antibody targeting the EGFR is limited to those patients whose tumor do not contain RAS gene. Again, the benefit of immunotherapy with immune checkpoint inhibitor is still limited to sector of patients that carry MSI high or deficient mismatch repair. In addition to the BRAF mutation, mixed responses to EGFR inhibitor, whether panitumumab or cetuximab, a single agent, or in combination with cytotoxic chemotherapy is unlikely. And the still coming data suggests the resistance may be overcome with concurrent use of BRAF inhibitor, such as vemurafenib. Again, the advances in the treatment of metastatic colorectal cancer led to the improvement in the survival from 12 months with fluorouracil as monotherapy to more than 3 years in selected studies. These findings across large randomized trials suggest that the primary tumor location is an important point for the tumor biology, and they make the substantial prognostic and predictive value is of enough. And again, it confirms that the right-sided and left-sided metastatic colorectal cancer clinically and biologically different, and another suggested by the recent insight into distribution of several molecular variables that differ by location. At this point, I will stop my talk and thank you all. If you would like to keep the question at the end of the session or to make it after, as you like. Dr. Saeed,
thank you very much, Professor Makhouri. In the interest of the time, if you permit, we're going to move on to Professor Faisal Dana, who is a professor of oncology at Acibadem Hospital. Professor Faisal was graduated from the University of Marmara and then had his training in internal medicine, followed by fellowship in oncology, and became assistant professor, followed by being full professor of oncology, and currently practices at Acibadem Hospital and Department of Medical Oncology. He's going to talk to us about molecular biomarker-based treatment of metastatic colorectal cancer. Professor Faisal, the mic is yours.
Thank you very much, Professor Said. Dear chairpersons, dear participants, I would like to thank the organizing committee for inviting me to this distinguished meeting. And as you see, the molecular biomarkers, my topic is the molecular biomarker-based treatment of metastatic colorectal cancer, of course, for the unresectable metastatic colorectal cancer. As you have seen from the previous speakers, colon cancer is a complex disease of molecular heterogeneity, and we are in the era of the precision medicine. And we need some predictive biomarkers to tailor treatment and to identify the patients who are more likely to respond to the specific therapeutic agents. Today, we have some molecular biomarkers and, of course, related pathways as potential targets. And we have a wide variety of drugs developed, including monoclonal antibodies, tyrosine kinase inhibitors, and immune checkpoint inhibitors. When we see a patient in the clinic, we should look at the factors that influence the treatment choice in metastatic colorectal cancer. We should look at the patient characteristics such as comorbidities of the patients, age of the patients, ECOG performance status, and the prior adjuvant treatment. We should look at the tumor characteristics such as if the tumor burden is high or low, if the tumor is resectable or not, and we should look at the tumor location as you have heard from the previous speaker. We should look at the molecular characteristics. Today, RAS status, BRAF status, MSI status, and HER2 status should be asked. And of course, we should look at the patient preference in terms of quality of life and the toxicity profile. By look at these factors, we tailor the therapy according to the individual patient's needs. In colorectal cancer, biomarker testing can be done from stage 2 colon cancer to stage 4. For example, for all colon cancers, including stage 2 and stage 3, mismatch repair status or microsatellite stability should be asked. In the metastatic setting, as you have heard, RAS status, BRAF status, HER2, and NTAP status should be asked from the patients. Biomarker testing in colorectal cancer should be done from the tissue biopsy specimens or liquid biopsies. Because most level 1 alterations are studied from biopsy specimens, in general, we use immunohistochemistry or PCR in most of the patients. But for the clinical studies, multi-gene next generation sequences may be done also. And in terms of liquid biopsies, circulating tumor DNA for comprehensive genomic profiling is ready for the clinic, but we still do not know how, where, and when to optimize it. Should we use liquid biopsies at diagnosis of metastatic disease, during treatment of metastatic disease, or at progression, or to detect early progression? This is the general treatment algorithm for metastatic colorectal cancer. For the BRAF and RAS wild type, in the right side tumors, we usually choose chemotherapy plus bevacizumab or anti-VEGF therapy. And for the left-sided tumors, in these patients, I personally use chemotherapy plus EGFR inhibitors. And after progression, we switch to chemotherapy. If the patient used an irinotecan-based therapy, we switch to oxaliplatin-based therapy. And if you use the EGFR inhibitor in the first line, after progression, we usually switch the biologics to VEGF therapy. For example, if the patients have BRAF V16 mutation, if the patient is young and fit enough, we usually choose folfoxirif, which is a triplet chemotherapy regimen, plus bevacizumab, or doublet chemotherapy regimen plus bevacizumab. Because there are some small phase 2 studies that have shown the efficacy of folfoxirif plus EGFR inhibitors, you may use, at least in some cases, folfoxirif plus panitumumab in these patients also. After progression, we generally switch to the BRAF inhibitor-based therapy. And for example, in the MSI high tumors, because the phase 3 trial have shown the efficacy of immunotherapy, we now consider the pembrolizumab as a standard therapy for MSI high tumors in the first line setting. And when we look at the RAS mutations, we know that the RAS mutations are most frequently mutated oncogenes, and it is seen in about 50% of the colon cancer. And KRAS is the most prevalent in these tumor types. In colorectal cancer, RAS testing is required prior to the EGFR therapy, and we do not use an anti-EGFR therapy in KRAS or NRAS mutation patients. If you use the EGFR treatment, it does not benefit in KRAS or RAS mutant tumors, even it may harm the patients also. BRAF mutations are the primary effector of RAS signaling, as you know, and BRAF mutations occur in about 10% of the colorectal cancers, and these mutations are mutually exclusive with RAS mutations. And this is a phase 3 study done in the BRAF V16E mutant colorectal cancer patients. These patients with BRAF mutations had progressed after 1 or 2 lines of prior systemic therapy. And these patients are about 600 patients were randomized to either BRAF inhibitor plus MEK inhibitor plus EGFR inhibitor, or BRAF inhibitor plus EGFR inhibitor, or investigator choice irinotecan-based chemotherapy. When we look at the Kaplan-Meier curves of these phase 3 trials, we see that the BRAF inhibitor-based triplet or doublet regimens has superior efficacy in terms of overall survival and objective tumor response when compared to the physician choice in irinotecan-based chemotherapy. And when we look at the progression-free survival, the triplet and the doublet and BRAF inhibitor-based chemotherapy therapies are superior in terms of progression-free survival also. Coming to the HER2 amplification, we know that the HER2 amplification can be seen in about 5% of the metastatic colorectal cancer patients. But if the patient has KRAS, NRAS, BRAF, and PIK3CA wild-type tumors, the rate of HER2 amplification can increase in about 30% of the patients. And here is a phase 2 Heracles study. In this study, they used anti-HER2 trastuzumab plus TKI inhibitor lapatinib for previously treated metastatic colorectal cancer. And as you see, by anti-HER2 therapy, in the majority of the patients, they got tumor shrinkage. And in about 30% of the patients, the objective response rate can be achieved. Here is the MyPathway phase 2 study, is a basket study, and they used trastuzumab plus pertuzumab. These are both monoclonal antibody against HER2. And when they used these combination treatments, they saw that at least over 30% of the patients, they got an objective tumor response in HER2 amplified patients. And here, tucatinib and trastuzumab are used in this phase 2 trial in the Mountaineer study. And here, the objective response rate is about 50%, is over 50%. And we know that in the majority of these patients, the disease control rate is about 80%. And there is an antibody drug conjugate in which the trastuzumab monoclonal antibody is linked to the topoisomerase 1 inhibitor deruxtecan. And this drug is used in the Destiny study, which is a phase 2 also with multi-cohort study. And in the cohort A, HER2 positive was in immunohistochemistry 3 positive or immunohistochemistry 2 or in situ hybridization positive cohort. When we look at the results, we see that in about in over 40% of the patient, the objective tumor response can be achieved by single agent trastuzumab deruxtecan, and the disease control rate is over 80% also. And these are the fascinating efficacy in terms of HER2 overexpressed tumors. And these are the progression-free survival and overall survival in the pre-treated patients. And trastuzumab deruxtecan achieved a median progression-free survival of about 7 months, and the median overall survival of about 18 months in the previously treated metastatic colorectal cancer. And these numbers are very effective and very fascinating. And we should also look at the MSI status of the patients. As you see in the Keynote 177 study, this study was done in the first-line MSI high metastatic colorectal cancer, and they randomized the MSI high patients to either PD-1 inhibitor pembrolizumab or standard chemotherapy. And when we look at the Kaplan-Meier curves of progression-free survival, we see that the single agent immunotherapy pembrolizumab doubled the progression-free survival when compared to the chemotherapy. And the objective tumor response is over 40% in the single agent pembrolizumab. And the median overall survival is about is not significant because of the follow-up, and the follow-up is not mentioned because. And in the checkmate 142, and nivolumab plus CTLA for ipilimumab was used in this phase 2 study. And we see that the overall response rate is 55% in the pre-treated patients, and about 80% of the patients, at least some amount of tumor reduction can be achieved by a combination of PD-1 inhibitor and CTLA-4 inhibitor, nivolumab and ipilimumab. There are some ongoing biomarker-based clinical trials in colorectal cancer, and these are some of the ongoing biomarker-based studies, as you see from the screen. In conclusion, molecular biomarker-based treatment for metastatic colorectal cancer leads to improved outcomes. There is no doubt about it. And biomarker analysis in all patients with colorectal cancer is extremely important in order to tailor the therapy. There are some relevant markers leading to change the therapeutic strategy in colorectal cancer. These are MSI, RAS, BRAF mutation status, HER2 status, NTARC fusion, and also there are some anecdotal reports related to ROS1 and anaplastic lymphoma kinase. And I would like to thank you for your attention.
Thank you, Professor Faisal, for this elegant presentation highlighting the importance of using biomarkers in metastatic colorectal cancer or unresectable disease. It's really important to highlight upon this issue, critical, very important. This is nowadays current status for metastatic colorectal cancer. Then coming to our next speaker, my colleague, Professor Dr. Saeed. He is a clinical oncologist in the Saudi German Hospital, Dubai. He is the head of the department. He is going to answer an important question. Is there any role for immune checkpoint inhibitors in colorectal cancer or not? Dr. Said, please go ahead.
Thank you so very much indeed, Professor Nakuri, and thank you to my previous colleagues who made my job really easy to just review a few trials that are important really with regard to the role of immune checkpoint inhibitors in colorectal cancer. So basically, we have always been jealous of lung cancer because obviously in the world of lung cancer, far before we started to characterize the colorectal cancer genomic landscape, they started to basically molecularly define that disease. But we have now, as our colleagues, and particularly in talk from Professor Faisal, you realize now we have started to kind of dissect colorectal cancer into the different molecular subtypes, and we have started to molecularly define this disease into smaller portions, and therefore make some therapeutic advances for this disease. However, this has not been really very well defined so far in terms of the markers of immune response to treatment. The markers of immune response to therapy in colorectal cancer mainly is limited to mismatch repair. So mismatch repair and microsatellites are, the microsatellites are a small repetitive DNA nucleotide which are basically spread across the whole genome of human. And mismatch repair happens during the time of replications where, between the two strands of the DNA. Instead of having a full match, sometimes there are some mutation that they cause mismatch. However, our cells, they have employed some machineries to repair those mismatches, and quite a lot of proteins involved there in mismatch repair mechanisms. Sometimes these repair machineries, they are also deficient, as we have seen in hereditary Lynch syndrome, for instance, which causes endometrial cancer in around 5% of the population, or colorectal cancer around 3% of the population. Sometimes deficiency of the mismatch repair machinery happens as a result of some sporadic mutations, for instance, methylation of MLH1, which can cause mismatch repair deficiency and subsequently microsatellite instability in 25% of endometrial cancer and 15% of colorectal cancer patients. So obviously, when you do not have a proficient mismatch repair machinery, it causes the accumulation of mutations in your microsatellites and subsequently cause some microsatellite instability, which we can see basically in two forms. Either we can see the deficiency of the mismatch repair proteins, as you can see on the right-hand side top part of the screen. For instance, you can see the deficiency of MLH1 in that immunohistochemistry on the right-hand side, as opposed to MSH2, or we can actually use PCR to identify the microsatellite instability comparing with the normal surrounding tissue. So you basically extract DNA from the tumor, and you also extract the DNA from the surrounding normal tissue, and then you look at the microsatellites basically between the normal and the cancerous tissue. And if you have more than 2 out of 5 microsatellite loci who are unstable, basically you call this this tumor as a microsatellitely unstable. What is the significance of microsatellite instability? And the significance is that once your microsatellite is unstable, you basically start to accumulate mutations. And accumulation of mutation, it causes increased mutational tumor burden, which basically in turn they increase the expression of the new antigens. And the expression of new antigens increase mutational burden. They subsequently may actually predispose the patient to benefit from checkpoint inhibitors. So as you can see in this this slide, we have quite a good concordance between the microsatellite instability and the high tumor mutational burden, but not so with the PD-L1 expression. So PD-L1 expression seems to be a different entity on its own, whereas microsatellite instability and high tumor mutational burden pretty much overlap. So this observation led to the first trials, phase 1 trials, basically 2015, where we observed that patients who have high microsatellite instability and mismatch repair deficiency, they benefit from checkpoint inhibitors. On the left-hand side of the slide, you can see the waterfall plot showing the response to the treatment with pembrolizumab, and on the top-hand side, you see that the biochemical response to the treatment. And both of these responses, they have of course led to the progression-free survival in colorectal cancer patients who are microsatellite unstable with MSI high, with the black bar on the top and the red bar for the microsatellite stable or mismatch repair proficient patients. So you can see that there is a gap between the two groups in terms of the response to treatment, also in terms of the overall and progression-free survival. So this is another trial which was a phase 2 open label trial of pembrolizumab in treatment refractory microsatellite unstable or high mismatch repair deficient patients, Keynote 165, which showed basically a very good response, an impressive response in terms of the reduction in the size of the tumor, as you can see on the left-hand side of the screen, and also an impressive progression-free survival and overall survival, as previously discussed by my colleagues, in order of around 30 to 40%. 3 years overall survival. So that's quite really an impressive response. However, this was a open label single arm, and it was not really a randomized trial. The same with checkpoint 142, which was nivolumab plus low-dose ipilimumab in previously treated dMMR and MSI high colorectal cancer patient, 120 patients, 119 patients basically who had more than one lines of previous treatment. They were treated with combination of nivolumab and low-dose ipilimumab, and basically they were followed up for a long period of time. You can see the waterfall plot showing an impressive response to the treatment, and also a very, very impressive progression-free survival of nearly 70% for 27 months, overall survival of again around 70% for 27 months of follow-up. There was an update in that presentation. 4 years of follow-up of nivolumab and low-dose ipilimumab showed an impressive response of 65%, and a good rate of complete response of 13%, 52% of partial response to treatment, as you can see on this waterfall plot. And again, you know, this is 4 years follow-up of these patients presented in Annals of Oncology this year, showing that the medium overall survival and progression-free survival is still not reached after 4 years of treatment, which is really quite impressive for that group of patients. This is obviously the adverse event, which is going to be reviewed in more detail by my colleague, next speaker. But as you can see, obviously, as expected, dual immune checkpoint inhibitor comes with a slightly higher risk of adverse event, but still very much expected from that category of medication, and fairly manageable. The next trial, which is a randomized trial, it's a phase 3 trial. The first phase 3 randomized trial is pembrolizumab versus chemotherapy in MSI high deficient mismatch repair metastatic colorectal cancer, patients with measurable disease first-line chemotherapy. So basically, these are treatment-naive patients who have been centrally tested and they have been confirmed as MSI high or deficient mismatch repair. They are all metastatic patients. They were randomized 1-to-1 between receiving pembrolizumab 200 milligram every 3 weeks or the chemotherapy of investigator's choice, and the co-primary endpoints are PFS and OS. You can see this is the response rate and duration of response. Response rate in pembrolizumab arm 45% against 33% in the chemotherapy arm. Obviously, the number of the percentage of the response as a complete response is much higher than the chemotherapy in group of patients who receive pembrolizumab, 13.1% as opposed to 3.9% in the chemotherapy arm. The partial response is fairly the same between the two groups, but what is important at the bottom of this table is that the response duration of more than 24 months, and that is very important, that after 24 months, the patient who are benefiting and then showing response is 83.5% in the pembrolizumab arm versus only 33.6% in chemotherapy arm. So based on that, really, it shows that it's a great response to treatment, and as you can see here, progression-free survival and overall survival again showing a considerable gap. Having said that, overall survival is not statistically significant, although that nominally is much improved with pembrolizumab. Based on this data, we have the confirmation of pembrolizumab as a standard of care for patients who are microsatellite high and or deficient mismatch repair in metastatic colorectal cancer as a first line of treatment. Again, the adverse event are expected of the adverse event that we know of the immune checkpoint inhibitors, and it's going to be reviewed in more detail by my colleague. But again, this group of patients, they have much more tolerable treatment compared with what you expect of the chemotherapy as well. And next immune checkpoint inhibitor is dostarlimab, which is from Pfizer, and basically this is a phase 1 clinical trial. One arm of this clinical trial was it is not from Pfizer, it is from GSK, I beg your pardon. So one arm of this trial was non-endometrial deficient mismatch repair basket, which had 173 patients on that, including colorectal cancer patients. You can see that the response rate in colorectal cancer, 36.2%, which is similar to the group of non-endometrial cancer. All of them, the overall response rate was 38.7%. The duration of response is also very respectable. You can see that more than 50% of the patient, they continue on the medicine after 1 year of treatment, and the median duration of response is not reached yet. Again, the toxicity profile is not different from the other checkpoint inhibitors. And in conclusion, pembrolizumab is a new standard of care in first-line metastatic colorectal deficient mismatch repair and MSI high, which has FDA and EMA approval. Combination of nivolumab plus low-dose ipilimumab also has EMA and FDA approval for patients with dMMR and MSI high metastatic colorectal cancer following fluoropyrimidine-based combination therapy. Pembrolizumab was also approved for dMMR and MSI high patients in solid cancer, regardless of type of cancer. Basically, those patients who have progressed on the previous treatment. And dostarlimab is a new checkpoint inhibitor, which has shown a very promising response in that group of patients. Obviously, we are waiting further clinical trials to have the confirmation. With all that, thank you so much indeed for your attention, and I will hand over to Professor Nakuri to introduce the next speaker. Thank you.
Thank you a lot, Prof. Saeed, for this excellent presentation highlighting the role of immunotherapy, whether single or in combination, for the effect and role in metastatic colorectal cancer. And our next speaker, our colleague from Egypt, Dr. Wissam El-Ghamri, he's going to highlight upon the adverse events of immunotherapy in metastatic colorectal cancer and how to manage. Dr. Wissam, the mic is yours. Please go ahead.
Thank you so much, Dr. for this introduction. The presentation will be shared from the organizing side. So please start the first slide. Unfortunately, this is the last talk in this fruitful scientific day. And I know that all the speakers and all the audience are overwhelmed by the large amount of scientific information they have received today. So I would like to make it simple and short, because talking about...
But ختامها مسك. The last is the best.
Last is the best. Last is the best. Last always is the best. And we are totally alerted with you. Don't care about it. Just get the whole information that you want.
ما فيش مشكلة إن شاء الله. So immune checkpoint inhibitor therapies are now considered as the rising star in the treatment of metastatic colorectal cancer, especially after introducing them as a first line of treatment recently. And most of the talks in this session highlighted upon this. Immune checkpoint inhibitors are now approved as monotherapy or in combination with chemotherapy and or other targeted agents in many options of different sites of cancer management. We can use it in head and neck and in GIT malignancies. We can use it also in cervical cancer and urothelial cancer. And also we can use it specifically in the colorectal cancer. Next. Always any medication has its own side effects. And this type of medication has its own type of adverse events. It's called immune-related adverse events. And they are and this presents a new spectrum of adverse events that differ from those. As we can see, some examples as encephalitis, aseptic meningitis, uveitis, hypothyroidism, hepatitis, adrenal insufficiency, enterocolitis, myalgia, pruritus, rash and vitiligo, pancreatitis, arthralgia. Next. So what are the risk factors for development of immune-mediated adverse events, immune-related adverse events? Patients with history of immune disease or who are being actively treated for an autoimmune disease are at risk for worsening of their autoimmune disease while on immune checkpoint inhibitors therapy. Patients who receive ipilimumab, which is anti-CTLA-4 after a PD-1 inhibitor, are at greater risk of development of immune-related adverse events as per retrospective studies. Patients with grade 3-4 toxicity on ipilimumab followed by PD-1 antibody developed grade 3-4 immune-related adverse events more than 20% of the cases. Next. So what are the patterns of immune-related adverse events? We can start with the onset. The median onset is like 5 to 12 weeks after initiation. 5 to 12 weeks, this is the average time, but we can see it months after starting of the treatment or even after discontinuation of the therapy. So what about the severity? The incidence is always higher with anti-CTLA-4 agents. High grade of adverse events with one checkpoint inhibitor class does not preclude safe administration with another class. So this means that changing between one class and another inside the immune checkpoint inhibitor means that they are also expecting the same side effects, not meaning that we can change from one class to another. This means that we are not going to face side effects. No, this is not right. Next. So what are the typical presentation of immune-related adverse events? We can start by some of them as the dermatological adverse event, which we can see them in the form of a maculopapular rash with or without pruritus, predominantly on the trunk, and to lesser extent the upper limbs spreading to extremities. Also, we can see them in the form of eczema or psoriaform manifestation, also blistering skin reactions. Another manifestation is colitis, which can be presented as diarrhea, abdominal pain, fever, vomiting. Also, the liver can be affected, but its affection is often asymptomatic and diagnosed via routine blood tests. And what about the pancreas? It may also be affected with the immune checkpoint inhibitor. Also, like the liver, it may be asymptomatic elevation in amylase and lipase. We can discover this by CT, as we can see the picture of pancreatitis. Also, it can be presented with severe abdominal pain, vomiting, and hemodynamic instability. What about the endocrine manifestations? It can be presented as headache, visual disturbances, fatigue, altered consciousness, deranged electrolytes, especially hyponatremia, and mood changes. Next. Pneumonitis also is one of the side effects that we can see with our patients, and it can be presented with dyspnea, cough, fever, chest pain. Also, the kidneys can be affected. It can be shown in the form of elevated serum creatinine, urine output change, and edema. The eyes also may be affected, and we can see this affection in the form of vision changes, photophobia, pain, eyelid swelling, and eye redness. What about the neurological manifestations? It appears as fluctuating muscle weakness, absent or reduced deep tendon reflexes, sensory motor deficient, headache, photophobia, neck stiffness with nausea and vomiting, confusion, altered behavior, seizures, and short-term memory loss. Also, the cardiovascular system, we can see some manifestations related to the side effects like dyspnea, edema, decrease in the ejection fraction by echo. Musculoskeletal adverse events of immune checkpoint inhibitors can be presented as joint pain, swelling, inflammatory symptoms, myalgia, and myositis. Next. So what are the general guidelines for management of immune-related adverse events? The most important issue to consult promptly with relevant specialists for affected organ system, and dose reduction of checkpoint inhibitor therapy is not a recommended strategy. Side effects or adverse events are graded. So grade 1, which is asymptomatic to mild symptoms, how are we going to deal with this? The general guidelines is observation, supportive care, intervention is not needed. Next. Grade 2, with moderate symptoms, local or non-invasive intervention may be indicated. Withhold the medication and consider resuming the treatment with full dose if toxicity resolved to grade 1 or less. low-dose corticosteroids may be needed or may be able to continue treatment. Grade 3, medically significant but not immediately life-threatening adverse events. Stop immunotherapy immediately. Hospitalization may be indicated. High-dose steroids indicated. Slow steroid tapering over more than 1 month until the toxicity resolves to less than or equal grade 1. What about grade 4 toxicity, which is life-threatening condition? Urgent intervention is indicated and permanently discontinue of the immunotherapy. Next. Steroid is a backbone in the treatment of immune-related adverse events. And how are we going with the doses? How are we going to deal with the steroid treatment and its drawbacks? Long term of the therapy, which may exceed 4 to 6 months, are sometimes needed to prevent the recurrence of adverse events. That's why that rapid taper is not advised, and taper may take at least 30 days. We have to monitor this with blood glucose, monitoring of adrenal sufficiency, and monitor muscle weakness. How can we prevent some adverse events which can take place due to long-term treatment with steroids as gastritis, which may be predisposed by the use of non-steroidal anti-inflammatory drugs or anticoagulation agent? We can use a proton pump or H2 blocker. The patient have increased chance to get opportunistic infection with steroid treatment, especially with dose of more than 20 milligram prednisone for more than a few weeks. So to protect him from pneumocystic cranii infection, we have to give sulfamethoxazone, trimethoprim, and for protection from fungal infection, we have to consider fluconazole. What about the effect of steroid on the bone? Osteoporosis may take place due to long-term use of steroids, and we have to do prophylactic measures by vitamin D and calcium supplements. Next, please. Starting with dermatological toxicity, here is a few pictures to demonstrate the forms of dermatological toxicity, which can appear in the form of psoriform lesion or maculopapular rash or lichenoid lesions. Next. The most common form of the dermatological toxicity is the maculopapular rash. We can do assessment by total body examination, including the mucosa. Ask the patient about any prior history of dermatologic autoimmune disease like eczema or psoriasis, and consider a biopsy if any unusual features may show. So what are the differential diagnoses? Any other causes which may lead to the appearance of this maculopapular rash rather than the immune checkpoint inhibitor used in the treatment of colorectal cancer. This may occur by chance due to a drug reaction, maybe due to cellulitis, contact dermatitis, radiation recall, or Stevens-Johnson syndrome. So how to manage this maculopapular rash? General supportive care, sun protection, oral antihistaminic or topical emollients. This medication differs according to the grade of the side effect or adverse event. If less than 10% of the body surface area, plus or minus other symptoms like pruritus, burning, tightness, we will continue the immunotherapy. We will treat with moderate potency topical steroids, oral antihistaminics for pruritus, and topical emollients. If grade 2 take place, which is 10 to 30% of the body surface area, with limiting instrumental daily activities, continue immunotherapy, treat with moderate to high potency topical steroids, and may add oral prednisone 0.5 milligram per kilogram per day, oral antihistaminics for pruritus, and topical emollients. If severe grade 3 to 4 side effect took place, which is manifested as affection of more than 30% of the body surface area, limiting self-care ADL, or potentially life-threatening, hold immunotherapy, treat with high potency topical steroids, prednisone 0.5 to 1 milligram per kilogram per day, and may be increased to 2 milligram per kilogram per day if there is no response on the initial dose. Urgent dermatologic consultation, and consider inpatient admission. Next. Gastrointestinal toxicity, which maybe take place in the form of diarrhea and colitis. Colitis is like abdominal cramping, abdominal pain, vomiting, fever, assessment, stool lactoferrin and or calprotectin, abdomen pelvic CT scan with contrast, differential diagnosis, dietary intolerance, other drug cause like antibiotics, stool evaluation for infectious etiology. General lines of management: supportive care, hydration, education about dietary changes, GI consultation, and consider colonoscopy. For grade 1 adverse event, which is defined as less than 4 stools above the baseline with no colitis symptoms, consider holding the immunotherapy, give antispasmodic, antidiarrheal. If refractory, negative for lactoferrin, add cholestyramine. What about the moderate degree, which can be defined as 4 to 6 stools above the normal? Colitis symptoms, ADL interference. ADL is activity daily living, which is a score to assessment done for the assessment of the daily living of the patients. It's like the ECOG scale or something like this. For the management, we have to hold the immunotherapy, prednisone or methylprednisolone 1 to 2 milligram per kilogram per day. If refractory, consider infliximab. If severe, which can be defined as more than 6 stools above the normal with colitis symptoms, ADL interference, hemodynamic instability, hospitalization, serious complications, hold the immune checkpoint, permanently discontinue any CTLA-4, methylprednisolone 1 to 2 milligram per kilogram per day IV. If refractory, consider infliximab inpatient care. Grade 4, which is life-threatening event as perforation, permanently discontinue immunotherapy, methylprednisolone 1 to 2 milligram per kilogram per day. Refractory, strongly consider infliximab and inpatient care. We cannot think about a re-challenge with the medication in any grade 3 or 4. Next. Hepatitis. Assessment will be done by liver function tests and INR, abdominal or CT, abdominal ultrasound or abdominal CT. Consider liver biopsy, hepatology consultation. Differential diagnosis: hepatotoxic medication, disease progression, viral infection, or alcohol use. Management: limit hepatotoxic drugs, eliminate alcohol use, and here, as a general rule, infliximab is contraindicated. If we are facing a grade 1 toxicity, which is defined by liver enzymes more than 3 times the upper normal limit and or total bilirubin more than 1.5 upper normal limit, we can consider holding immunotherapy and monitoring liver function tests more frequently. Grade 2 adverse events, liver enzymes more than 3, less than 5 upper normal level, and or total bilirubin more than 1.5 till 3 upper normal level. Hold immunotherapy, monitor liver function tests every 3 to 5 days, and consider prednisone half to 1 milligram per kilogram per day. If you are dealing with grade 3 toxicity defined by liver enzymes more than 5 to less than 20 the upper normal level, and or total bilirubin more than 3 to 10 folds, hold the immune checkpoint inhibitor prednisone 1 to 2 milligram per kilogram per day, and if refractory and no improvement in 3 days, mycophenolate mofetil 500 milligram oral BID can be used. Hepatology consultation, consider inpatient care, and monitor liver function tests every 1 to 5 days. If we are dealing with a grade 4 adverse event defined by liver enzymes more than 20 folds and or total bilirubin more than 10 folds, permanently discontinue the immune checkpoint inhibitor, prednisone or methylprednisolone 1 to 2 milligram per kilogram per day. If refractory or no improvement in 3 days, add MMF, hepatology consultation with inpatient care, monitoring of the liver function tests daily. Do not try to re-challenge with the medication while facing with grade 3 to 4 adverse events. Next. Endocrine toxicity, there is a broad spectrum of endocrine toxicity, and we are just, as this is a very large variety, we are going to take thyroid adverse event as an example in this talk. Assessment can be done by close laboratory monitoring and monitoring TSH and free T4 every 4 to 6 weeks. Differential diagnosis, infection or brain metastasis. Management is a form of levothyroxine, adjust level to maintain free T4 level at mid-range, likely needs lifetime hormonal replacement. Asymptomatic hypothyroidism can be presented by elevated TSH while normal free T4. If the TSH4 to less than 10 folds normal free T4, if TSH is 4 to less than 10 folds and normal free T4, asymptomatic will continue the treatment with immune checkpoint inhibitor. TSH more than 10 fold while normal free T4, continue using medication and consider levothyroxine. In case of normal or low TSH, low free T4, consider central hypothyroidism to exclude thyrotoxicosis recovery. Clinical primary hypothyroidism manifested by high TSH more than 10 folds, low free T4, and symptomatic. Monitor TSH every 3 to 4 weeks. Continue immune checkpoint inhibitor. Initiate levothyroxine. Consider endocrine consultation while exclude concomitant adrenal insufficiency. Thyrotoxicosis, low TSH, high T4. If asymptomatic, continue immune checkpoint inhibitor. Consider propranolol for palpitation. Repeat thyroid function tests every 4 to 6 weeks. Often evolves to hypothyroidism requiring levothyroxine. Do not re-challenge in symptomatic pituitary inflammation. Next. Immunotherapy-induced pneumonitis. Now in the era of COVID-19 pandemic, we have to give it special attention. Pneumonitis is defined as focal or diffused inflammation of the lung parenchyma Pneumonitis may present asymptomatic and be incidentally found on CT or present with symptoms like cough, dyspnea, fatigue, or chest pain, or a clinical finding of progressive hypoxia and respiratory failure. Axial CT chest obtained 4 months after initiating of nivolumab therapy, showing multifocal peripheral and subpleural mild and lower lung airspace consolidation. And this is a picture. This picture is an example of what we can see from the adverse event of immune checkpoint inhibitors regarding the lung. Next. How can we assess pneumonitis? First thing is the oxygen saturation follow-up and sputum culture nasal swab, chest X-ray, CT chest, plus or minus angiography. What are the differential diagnoses? Infection, disease progression, pulmonary embolism, and pleural effusion. Management. The general rules are to stop smoking, vaccination, dyspnea management, oxygen support, and nebulizer. In management of grade 1 pneumonitis, consider holding immunotherapy, reassess in 1 to 2 weeks, consider chest imaging with CT. If dealing with grade 2 pneumonitis, hold the immunotherapy, prednisone 1 to 2 milligram per kilogram per day, and if refractory, treat as, what are we going to say in grade 3? Consider pulmonary consultation and consider infection workup with CT chest and be repeated every 3 to 4 weeks. If we are going to face a grade 3 to 4, grade 3 can be defined as severe symptoms limiting self-care or oxygen indicated, while grade 4 life-threatening respiratory compromise. Permanently discontinue the immunotherapy. Give methylprednisolone 1 to 2 milligram per kilogram per day. If refractory, we can add infliximab, IVIG, MMF. Pulmonary consultation, of course, infection workup, bronchoscopy with bronchoalveolar lavage plus or minus biopsy, and empiric antibiotic. Do not try to re-challenge with immune checkpoint inhibitor in any grade 3 to 4 toxicity. Next. COVID-19 and immunotherapy. Patients with cancer may already have impaired immune system response due to underlying cancer and or treatment effect. Immunotherapy, most commonly with immune checkpoint inhibitors, attempt to reactivate certain exhaust immune cells. How this may affect response to COVID-19 infection and management or COVID-19 vaccination still remains unclear. Next. So this will be my last slide containing the take-home message that immune checkpoint inhibitors are effective therapies. Biomarker testing is mandatory to ensure that the right patient is matched to the right therapy. Steroids can be used to manage almost all immune-related adverse events. Multiple adverse-related events can occur in any patient. It is important that patients are kept safe with education of the medical team, the patient, and the caregiver about immune-related adverse events while receiving immunotherapies. Next. Thank you so much for your time, and I hope that it was not any boring for anyone. Thank you.
It was really an interesting and very comprehensive review of the toxicity of checkpoint inhibitors, which will be a kind of a routine treatment from now on for a subset of this colorectal cancer patient. We are a little bit late at the moment. I'm sure that a lot of people, they have stayed on this this symposium until late, so I don't really want to take too much of time. We may have only one time for one question, and that is a question for Dr. Professor Al-Nakouri. And basically, the question is that for patients with left-sided metastatic colon cancer, started on bevacizumab with chemotherapy with good response. Then molecular results came, and this patient is KRAS wild type. In your opinion, would you switch the patient to anti-EGFR, or would you continue with bevacizumab?
Yeah, it's a very, very smart question, actually. But for me, if the patient do favorably with the good response, subjective and objective response, for example, I will continue on beva-based combination chemotherapy until if there is progression. So I will keep anti-EGFR like a second weapon in the future.
Perfect. Thank you so much indeed.
Excuse me, I have another question to Dr. Wissam. The dose of infliximab.
Yes, doctor, the dose of infliximab. So what is infliximab? Infliximab is a tumor necrosis factor alpha blocker. We are not as oncologists familiar with the use of this medication a lot. It's used mainly by the GI consultant in the treatment of inflammatory bowel disease. But as much as I recall, it will be 5 milligram per kilogram, and it will be given after the failure of steroids to control the manifestation. We can give the steroids like 2 to 3 days, and if it is refractory to steroid treatment, we can initiate the treatment with infliximab. It will be 3 doses, week 0, week 2, and week 6.
Okay, another question to Professor Dr. Saeed. If you go back to your slides for the keynote 177, if you see the initial curves during the first 12 months, you will find there is a crossing curves. First, with initial favorably better with the chemotherapy, and then the curve of the chemotherapy coming down and crossing the curve of the immunotherapy. So for this crossing curve initially, do you think if we start pembro with combination chemotherapy, on the long run, those patients will do better than already existing with pembrolizumab?
It's a very good question. Obviously, we have this strategy, employed this strategy in some of the cancers, such as triple negative breast cancer. And as you know, those group of patients, the idea is that, you increase the new antigens and then subsequently increase the response to immune checkpoint inhibitors. However, in microsatellite unstable patients and deficient MMR patient, you expect that this group of patients, they accumulate mutation, tumor mutational burden is already very high, and therefore these patients, they may have high response to immune checkpoint inhibitors. Having said that, from the curve that you just mentioned, yes, there is a group of patients, especially at the beginning of the curve, that they do worse with the immune checkpoint. And maybe actually, this group of patients, they benefit from the combination to receive either chemotherapy concurrently with immune checkpoint inhibitors, or immunotherapy first, then followed by immune checkpoint inhibitors.
Yeah, totally agree with you. Very, very excellent answer, actually. From my side, I don't have any further question. Maybe there is a question there in the from the audience. I'm not sure. Anyone has any further comments or feedback? So just one more question to Professor Dr. Faisal. From let us say practical point of view, what's the molecular markers you are asking at first presentation for those cases with metastatic colorectal cancer, and what other markers you are asking later on?
First, when we faced the metastatic colorectal cancer, we asked for the RAS mutation, BRAF mutation, MSI, and HER2. But you know, HER2, anti-HER2 therapies cannot be given in the first line. And because of that, you may postpone the HER2 test after, let's say, 1 or 2 line of chemotherapy. But at the beginning, we ask for HER2 also.
Yeah.
And we do ask for the immunohistochemistry or PCR tests. We do not do multi-gene NGS panel. And because of that, we do not ask for the ANTARC or ROS or anaplastic lymphoma kinase ALK fusion.
So what about your, this recent data for the BRAF mutation that showed or carries a poor prognostic issues with the metastatic colorectal cancer, although it's little bit low incidence, like 5–10% by maximum. However, the mixed response to anti-EGFR low or unlikely. So in this situation, do you recommend adding like encorafenib to anti-EGFR or not?
To the first line, you mean, or second line?
Second line.
Yeah, in the second line, we are using BRAF inhibitors, not encorafenib, but we have in Turkey vemurafenib and dabrafenib.
Yeah.
We use dabrafenib or vemurafenib in combination with EGFR as an off-label use.
Off-label, yes. And in your personal experience, in doing better?
Yes, combination of BRAF and EGFR inhibitor is much more superior to second-line chemotherapy.
Yeah, so it do like overcoming the resistance to anti-EGFR?
At
like
least
that?
we think
At
so.
least.
At
Yeah.
least we think so.
Very good. So at this point, we can close the last session of this perfect symposium. I do congratulate the whole members, and the mic is to you, Professor Dr. Ihab Saad, the chairperson. He is the the hidden soldier in this symposium. Dr. Ihab, the floor of you.
Thank you so much, Professor Ihab. I'm learning from you everything, Dr. Ihab. First, I'd like to thank our audience. We reached in the early morning session 450, and in the evening session about 500 or 450 as well. Hopefully, all our attendees get the knowledge and the experience that aim for from this meeting. This was our first international multidisciplinary meeting in our group. I'd like to thank all our colleagues and professors. One by one, I'd like to thank Professor Mustafa Shazli, Professor Amr Abdal, Professor Yani Shmad, Professor Ender Blondo, Professor Volkan Kera, Professor Shafiq, and Professor Hamid. Also, I'd like to thank Professor Erdel, Professor Anwar, Professor Wissam, Professor Faisal, and of course, our Professor Dr. Ihab Nakouri and Professor Saeed for their great contribution. I'm supposed to have a closing remark, but unfortunately, for the sake of time, we actually a little bit late by 2 hours rather than our timetable. So I'll be enough with the conclusions that was highlighted by every chairperson in every session. Thank you so much for being with us. It was an honor and pleasure. Myself, I got a lot of experience from every one of you. It was extremely thoughtful. Inshallah, we will have a systematic meeting like this. Hopefully, inshallah, we can do it every month. Next month, we are planning to have a hepatobiliary day. Hopefully, we can welcome all of you physically in our group with vanishing of the restriction and the social distance and the pandemic. We are planning to have next meeting to be a physical. Again, thank you so much. Much appreciated your effort, your time, your knowledge, your presentation.
Thank you.
Your participation. This from my side. If any one of you, one of our colleagues, want to say something to our audience, to the other colleague, please go ahead. Feel free. Any last comment from any one of our colleagues?
Yeah, I'm just one comment to the audience, and especially to the public audience, if there is any, or for publicity, is that colorectal cancer is one of the preventable cancers. I mean, we have some issues to do to detect some cancers early. However, in other situations, we can do other tests to prevent cancer. And our case, colorectal cancer, can be prevented by doing a proper screening program that can early detect polyp. This polyp maybe later on in the future will turn out to be malignant. So by removing this polyp, you can prevent malignancy. That's why I encourage the publicity to go for screening program as indicated.
Dr. Saeed, any last comment for the colleague or for the audience?
No, thank you so much indeed, Professor Hiba. Obviously, it was your enthusiasm and your passion that drove this meeting, and thank you so much indeed for that, and to our guest speakers and our very esteemed professor who basically made this conference possible. And like what Professor Hihab said, we would hope that the next meeting we could have a physical meeting. And thank you so much indeed to our very good audience who stayed with us until late. So all the very best.
Our Turkish marvelous team.
Excuse me. I congratulate you, because it is very difficult nowadays to do such a kind of successful meeting with many participants. Really, it's a fantastic organization. Thank you very much for everything.
It will be a nucleus for our cooperation. We as inshallah, we are testing ourselves. Inshallah. Dr. Faisal, Dr. Walton, Dr. Erdem, you want to add anything? Any last comment?
No, thank you very much for the very, very, very distinguished meeting for the organization. Thank you very much.
My friend, Professor Erdem, I know we just condensed our session, but hopefully, inshallah, next time we will have a lot of discussion about HIPIC and the future of HIPIC. You want to say any last comment? Or?
Yes, thank you very much. It was a wonderful symposium. Yes, there are a lot of discussion about HIPIC, prophetic HIPIC, because there are little standard about HIPIC procedure. So there are a lot of discussion about this. I hope next time we can discuss about this. Thank you very much.
Inshallah, we will start next time with HIPIC session before the colorectal session. Even in the hepatobiliary day, we will give them a HIPIC session as well. Dr. Wissam, Dr. Anwar, you want to say anything at the end of this session?
Thank you very much, Prof. Ihab, for having us in this great symposium. It was a great opportunity to discuss all this knowledge. I learned a lot of issues, especially surgical ones. And for the audience, I would like to say there is always a big hope, actually, even with the specific setting of disease. And I would like to thank all and understand the audience, and see you, inshallah, in good health all. Be safe. Thank you very much.
Wissam?
Thank you very much. This was a really great symposium with many great speakers. Inshallah, each time will be better and better. And I hope that next time will be even better, and the talk will be of great benefit, inshallah, to any of my colleagues and the audience. And hope to see you all soon in the next event, inshallah. Thank you.
Shop it. We started with you, Shop it, and we'll end with you. Do you want to say something before we close? Mr. Shobit, our black horse guy.
Thank you so much, everyone. So yeah, I'm just the organizer, but the main task was Professor Yab and all the speakers. Thank you so much for joining, and looking forward for the next successful session we'll have very soon. Thank you so much.
Thank you so much for all of you. Thank you, my friend and my colleague. Seeing you, inshallah, all of you, inshallah, physically, and I can welcome you, inshallah, Saudi Arabia by myself. Next time, inshallah. See you. Bye bye.